Shikhar, we should start.
Yes, sir. We should start.
Yeah. So, good morning, good afternoon, good evening, friends from around the world, and welcome to the World Tour Eastern Hemisphere. And we have divided this entire program into two sessions. The first session is the malignant tumors of the skull base, and the other is oral rehabilitation after fibula reconstruction. These are two very relevant and upcoming thematic areas in the clinical service of head and neck department. We have very eminent speakers from around the globe, particularly from the Eastern Hemisphere, who have volunteered to join the meeting. And I thank all of them for and apologize for keeping them away from their family on a weekend. So our first speaker is Dr. Prathamesh Pai, who will give a keynote address. And then we have the moderator with him, Dr. Yiming Zhu from China, who will moderate the panel discussion on outcomes of skull-base surgery around the world. So over to you, Prathamesh, for your keynote speaker. And then we will have the question and answer during the panel discussion itself. Over to you, Prathamesh.
Thank you, Pankaj, for that introduction, and thank you for the invitation to speak at this Ifhnos World Tour, the Eastern Hemisphere. My mandate is to speak on the outcomes in skull-base surgery around the globe. And what we will discuss is how it has evolved across the years from the evolution of the surgery. So we all know about skull-base surgery is the junctional area between the neurocranium and the viscerocranium. And all these tumors are having in and around it complex anatomy, varied histology, and we require a myriad of approaches to reach this. Also, we realize that there's limited experience amongst various surgical specialties, and hence the skull-base tumors remain an enigma. Way back in '63, Professor Alfred Ketchum, described the anterior craniofacial resection, and he made it into a safe surgery. And thereafter, there have been a lot of improvements and refinements in this. And a lot of these patients who were thus far declared incurable were being treated. Yet we realize that they form a fraction of the head and neck tumors seen. They're mostly non-squamous, and they are having a unique feature compared to a routine squamous cell cancer. They are different cancers, and that's why we need to deal with them in a different way. This brings about the need for collation of data for meaningful analysis, because every institution would have very few cases being done. So way back in 2000, Professor Jatin Shah developed the international study for skull-base surgery, and almost 17 institutions across the world participated in this. They collated data from 1956 to 2000, and 1,300 cases were eligible for analysis. So they found out that their 5-year disease-specific survival was around 60%. The impact of histology was immense. The eustachian neoplasmas, skin cancers, low-grade sarcomas did exceedingly well in comparison to the mucosal melanomas and undifferentiated tumors, which survived less than 30%. And the rest were in the middle. When they looked at intracranial extensions, the ones that did not have intracranial extension did the best. And in contrast, when the brain was involved, the survival dropped down by almost 50%. Margins of surgical resection, we are all aware, are very important. What you realize is in skull-base surgery, almost 30% of these would have close or positive margins. And when we looked at the impact on the survival, the ones who were negative did almost twice as well as the ones that were positive or close. When we looked at the multivariate analysis, what stands out is that the histology, intracranial involvement, and margins were significantly responsible for recurrence-free survival, disease-specific survival, and overall survival. Now, this data set contributed to 5 important publications over the next 5 years, and they actually set the benchmark for the data now available across the world. The factors impacting upon outcomes were identified, and case selection was possible for better outcomes. And in future, these outcomes would be compared, and we would know how the current outcomes and treatment outcomes would be impactful. There are certain disadvantages of the external skull base surgery. You have external incisions, you have a need for craniotomy, there's morbidity and complications, there's costs involved due to length of hospitalization, and aesthetic and functional outcomes and quality of life are affected. So, over the past 2 decades, from 2000, there have been certain refinements. There has been an entire rethink on the approach of an R block resection. There have been technological advances. Endoscopic surgery has come into realm from benign to malignant. Neuronavigation has helped in evaluate the cancers intraoperatively. Immunohistochemistry and molecular pathology have characterized these tumors further, helping us understand their biology. And targeted chemotherapy has come in to help us in the ones that are unresectable. So when you look at sinonasal cancers and surgery, R block is a myth. We are dealing with tumors in between the orbit, below the skull, and anterior to the carotid artery. So does really wide exposure equate wide margins? We know that sequential and multi-block resection is effective where the complete clearance at the base is paramount. So there are certain advantages of endonasal skull base surgery. It avoids external incisions. There are no aesthetic sequelae, avoids a craniotomy, reduces blood loss. Total tumor resection is possible as in an open resection, and you can repair the dura as well. So any tumor today which would be dealt with these kind of approaches, the medial maxillectomy to the Rave subfrontal craniotomy, these can be done with endoscopic assistance. So if you look at a subcranial pathology, where the anterior facial skeleton and palate are important decision makers, if they are free, you can consider doing an endonasal approach. And if they are involved, you certainly need to do an open approach. So you can do a complete endonasal resection for these tumors that do not reach the anterior skull base. For large tumors which have now gone transcranial, again, if the anterior facial skeleton is free, you can do a cranioendoscopic resection. And if you have a minimal intracranial extension, then a complete endonasal craniectomy and resection akin to a craniofacial resection is possible. So you have got 2 approaches where you can use endoscope, either endonasal endoscopic resection with craniotomy or a cranioendoscopic resection. There have been certain impactful advances. We have known from this data set from Lisa Licitra that the intestinal adenocarcinomas, which are P53 wild type, 40% achieved pathological complete response. And the ones that were PCR had 100% disease-free survival at 55 months. The ones that were requiring craniofacial and were given induction chemotherapy did exceedingly well when they were wild type P53. So P53 may be a key to better prognostication with induction chemotherapy. Likewise, in esthesioneuoblastomas and sinonasal neuroendocrine tumors, we have seen in our data set from an institution that 52% became resectable, and the 2-year progression-free survival was 75%. Likewise, in squamous cell cancer, this data from MD Anderson showed that 76% had partial response. And the ones that had partial response did exceedingly better than the ones that had progressive disease or stable disease. So you have tumors such as this, wherein your concerns are about the dura, the orbit, and with chemotherapy, they completely shrink. and you might alter your surgical resection. High-grade neuroendocrine tumors, where the concern is about the resection of the orbit, the skull base, and the dura, it transforms when you give neoadjuvant chemotherapy and there is a response. A teratocarcinosarcoma, again a high-grade tumor requiring extensive surgery, would reduce in its extent when given 2 cycles of neoadjuvant chemo. So we are seeing tumors getting converted from inoperable to operable, preservation of orbit, avoidance of dural resection, and a conversion to a minimal resection with the use of the neoadjuvant chemotherapy. So 25 years later, in 2022, Professor Jatin Shah again requested 25 institutions to participate. He formed a group in MSKCC led by Doran Adelbey, and all these institutions participated, and we had collated about 2,483 cases. Now, this data set collected was similar to the one in 22, with the difference being in the newer treatment modalities being adopted. Again, we see from the data set that majority of the tumors were ethmoid and nasal cavity tumors. And approaches now included endoscopic and endoscopic assisted. So almost 50% of the cases today are somewhat endonasal or endonasal assisted. And we find that the negative margin with endoscopic approaches is similar to, if not better, than the open. When you look at the complication rates, look at the CSF leaks, half that of open, and meningitis is again 1/3 that of an open approach. The survival has been 66% at overall survival, and the cancer-specific survival, a death rate is around 30%. So when you look at the multivariate analysis again, what comes into focus is the 3 factors that we looked at earlier. Again, all of them seem to have a major role in the overall survival and the cancer-specific death. Again, looking at all the histologies, the ones that were low grade did exceedingly better. The adenocarcinoma stood out and did exceedingly well as compared to the mucosal melanomas. The intracranial extension again had a bearing. The ones that had no intracranial extension did far better than the ones that had brain involvement. The margins again stood out. The negative margins did twice as well, the ones with positive margins. So to summarize, in this data set, we found that the complication rates were better with endoscopic approaches. The survival was impacted by histology, intracranial extension, margins, and comorbidity. The overall survival had a modest improvement of 6% from the last analysis. The role of neoadjuvant chemotherapy is being considered but is unclear. Prior radiation did not impact the tumor control. And what we are seeing now is the use of free flaps, which increase our intensity of resection as well. Another data set that was instituted was only endoscopic resections of sinonasal tumors. 1,360 patients were collated in this data set. And we find when they compared the European series versus the validation series from Canada and India, 2 things stood out. The prognosis is closely related to the histology. The 5-year overall survival was 72%. The ones that had mucosal melanomas and neuroendocrine tumors did extremely poorly in comparison to the esthesionoblastomas and the non-adenoid cystic minor salivary gland tumors. Age was found to be independently affecting prognosis. The intestinal type adenocarcinomas, the esthesionoblastomas, and the mesenchymal tumors did better when they were less than 60 years of age. Looking at local control, the 5-year local recurrence-free survival in mucosal melanomas was 40% in comparison to the esthesionoblastomas, which was 91%. The distant metastatic relapse for certain histologies, the mucosal melanomas, neuroendocrine, and adenoid cystics had a higher distant metastatic potential. The regional control was optimal. More than 80% had this regional control recurrence-free control rates at 5 years. What is surprising is that gender, when you looked at the male esthesionoblastomas and minor salivary glands, they had a higher risk of nodal recurrence and death, while the women had a higher chance of nodal recurrence if they had the high-grade neuroendocrine and undifferentiated cancers. So tumor grade and subtype is associated with prognostic outcomes. So when you look at the entire series, again, as it was seen in the international collaborative group, the high-grade tumors did exceedingly better than the low grade. Sorry, the low grade did exceedingly better than the high-grade tumors. Among the ITACs, the papillary or colonic or mixed type did better than the mucinous. Among the squamous, the well-differentiated cancers did the best. Among the esthesionoblastomas, the Heims 1 or 2 did better than the Heims 3 or 4. In mesenchymal tumors, the high-grade tumors did worse off as did in the minor salivary gland tumors. So what we realize is that molecular classification is important, and it represents a promising step forward to increase the precision of sinonasal oncology. This will enable the development of tailored systemic therapy. So in summary, histology determines your survival. The immunohistochemistry is an essential part of pathology. Most high-grade tumors of neural epithelium will receive chemotherapy. We can consider chemotherapy in wild type P53 and sinonasal in intestinal type adenocarcinomas. 90% of subcranial tumors will be resected endoscopically today. And in 40% of transcranial tumors, you will use the endoscope for some sort of assistance. And we need to collect tissue for molecular characterization. Thank you very much for a very patient listening.
So Prathamesh, you can start the panel discussion, and Yiming is also here. So both of you can begin on that.
Okay. Have our panelists joined in?
Yeah, so I see Seichi, I see KK and Sarbani. Ben also I can see. So can all the panelists switch on their video, please?
Good morning, everybody.
Good morning.
Good morning.
Good morning.
Good morning.
Welcome to this skull-based panel and in this Ifhnos virtual world tour. Professor Yiming Zhu and me will moderate this panel. And what we will like to do is get your thoughts on certain managements of tumors, which we will commonly see in our practice today. So let us begin with the first panel, first case. It's a 33-year-old male with left nasal blockage for 5 months, left neck swelling since 4 months. He has had sinonasal surgery done twice in the past, 4 years and 2 years ago. On examination, there was a fleshy mass seen in the left nasal cavity, and the neck showed a left level 1B and 4 firm but mobile lymph nodes. The FNAC from these lymph nodes suggested a metastatic carcinoma of neuroendocrine differentiation. And the histopathology of the nasal mass suggests a high-grade sinonasal tumor with neuroendocrine differentiation. They gave a differential diagnosis, esthesioneuroblastoma Heims grade 4, or a sinonasal neuroendocrine tumor. So I'll just post some of these cases, images. Can you see the images on your screen now?
Yes.
This is a coronal T1 weighted image. And this is the post-contrast T1. You can see the mass occupying the nasoethmoid region. The axial scans showing the tumor in the entire ethmoid from anterior to posterior, coming in close proximity to the orbit. And the sagittal scans, the T2 and the T1 post-contrast, showing in coming proximity to the cribriform fillet. So this is something that we will all deal with in our practice, and we will come across these patients having had some surgery for polyposis in their institutions. So I would like to ask the panel, Professor Yoshimoto and Krishna Kumar, any further imaging you would want in this?
We like to get the CT scan and check the bone reconstruction or not, all right?
Okay, yeah. So you will do a CT along with the MRI as a complementary tool.
Also, we like to the PET CT, so we like to check the distant metastasis.
So why would you want to do a PET CT?
Mm.
Would a CT scan of the thorax or be sufficient? Do you really feel that these patients would have a higher incidence of distant metastasis? Professor Yoshimoto, you do it as a institutional practice, doing a PET CT scan?
Yes, in Japan, the PET CT is covered by the public medical insurance system, so we are not difficult to take a PET CT for all malignant case.
Right. Krishna, KK?
Yeah. Pratmesh, differ a little bit. Usually when we see such a sinonasal cancers, the usual first imaging investigation we ask is an MRI. And if the radiologist has some difficulty in interpreting the bone invasion or something, they do some correlation CT scans, which will definitely help. As far as PET CT is concerned, we don't do it usually regularly, but CT thorax non-contrast is a usual thing. And that's how we do the evaluation initially.
Sarbani, any comments?
This patient, I would, in addition to the MRI that has been done, I would also like a PET-CT because the differential is between an esthesioneuroblastoma Hyams 4 and a SNEC.
Right.
So I would want to do a PET-CT to rule out distant metastatic disease. Of course, what Krishna Kumar is saying about doing an NCCT thorax is also acceptable. But I would also like to look at the bones. So I think a PET-CT will be a one-stop shop. So I would do a PET-CT in addition to the MRI. And if you're asking about any other ancillary tests, I would also do an ophthalm evaluation in this case, because posteriorly the lesion seems to be extending close to the orbital apex. It would be important to know what is the present visual status, because it will have an impact later on.
Okay. Elaine, you want to ask anything?
What about the lymph node evaluations? Will you use ultrasound?
No, as far as the node is concerned, already it's an FNAC done. But if not, the imaging evaluation would be the MRI itself, and of course there will be a USG guided FNAC to characterize the node.
Okay, thank you. That's what I think.
Okay. So what we also practice in our institute as a protocol is to do PET CT scan in all the high grade tumors. The reason we do that is, as Professor Yoshimoto said, you want to rule out distant metastasis. Having said that, when we analyzed all our PET CT scans done, we realized that less than 4% of them had distant metastasis. So this brings into focus the thought that Dr. Krishna Kumar brought about, that if you are, and most of the metastases were in the lung or in the spine. So if you do a CT thorax, possibly you might be able to get the control of these distant metastases as well. But having said that, as Sarbani and Professor Yoshimoto also mentioned, that you would want to consider other therapies, and in that scenario, a PET CT scan will give you a better idea about the response in contrast to a CT or an MRI. So in that context, maybe a PET CT scan might be a better idea. Would the panelists agree on this?
Yes.
Okay. So I would like to ask. Yeah.
Can I add something?
Yes, please.
Pratmesh? Yeah, I just want to bring in a point. We usually see cases here. It is like years before the case was operated. But usually we come across cases like operated in a local or an outside center like 2 weeks back or 3 weeks back for a polyposis, and they come. So, so in that setting, probably what would be the imaging, and when should we do the imaging? That's one thing we are always discussing.
Right. So Professor Yoshimoto, the question Dr. Krishna Kumar is asking, if a patient has undergone redo surgery elsewhere, a surgery elsewhere, like a polypectomy, then how would you image this patient? Would it change your imaging, or this is the standard imaging you do?
The small imaging?
Yeah. If the patient has undergone any surgery before he comes to you.
First, so before the starting the treatment, so we like to make sure the pathologic diagnosis. I think that this patient is not diagnosed correctly. So I think this is a neuroendocrine tumor or the olfactory neuroblastoma, but we like to select the treatment according to the final diagnosis pathologically. So that's a neuroendocrine, and the olfactory neuroblastoma is a little bit different. So I like to the more biopsy from the nasal cavity in the office. So, but this tumor is embedded in the left sphenoid sinus. I think it's the upfront surgery is impossible, I think. Before that, we like to make sure the diagnosis.
Right. Good afternoon, Professor Palinza. Welcome to the panel.
Yes, good afternoon. How are you?
I'm fine.
Good. So just a couple of comments from my point of view. I agree with what everyone said. You need to know whether the periorbiter needs to go. You need a structural CT to do that. When we do a PET CT, the quality of the CT isn't as good as a sub-millimeter CT. So we've got to do a PET CT and we've got to do a CT as well. The other reason we'll do a PET CT in this case is you've got nodes in one side of the neck already. You've got a central skull-based lesion which can spread to both necks. So you really need it to assess the other neck to see what you're going to do with the other neck as well.
Right. So the question now is, would anybody consider neoadjuvant chemotherapy in these patients? And if so, which one, and what is your practice?
So Prathamesh, I think Krishna Kumar asked the question as to when would you do imaging if the patient was recently operated outside somewhere. So I think he had a very valid question, because that is something that we see very commonly in our setups.
Right.
And maybe we would wait for about 6 to 8 weeks, because to just kind of let all the acute inflammation and the changes settle down and get the right and adequate information to proceed. Is that right?
So if you're done, as Dr. Yoshimoto was saying, that you would do a diagnostic nasal endoscopy. You would want to assess whether there has been a completeness of resection. And if you had the previous imaging and you are seeing that the disease was completely resected, then you would have to actually look at what is the histology, and then make a decision whether you would want to proceed by observation or would you want to do a definitive treatment. Ben Yiming, any thoughts?
If the patient come to me post-operatively, even if it just has been 1 or 2 weeks, I will do an MRI first and the endoscopic evaluation to see how is everything going. I will review the history and review the operation, and to check the image. If there are major or prominent tumors left, I will try a pathologic diagnosis, and if it confirms there are tumor left, we will consider treatment immediately. And if it looks all the operation space looks quite clear, just some information, and there are not so clear tumors on the image, I will ask the patients to come back at 2 or 3 months.
Okay. Then what is your practice?
Is this the situation where you've had an operation prior and then they've been sent to your unit. Is that what we're considering?
Yeah. Right.
Yeah. So most of the time, decent pre-op imaging, so we can rely on the imaging that was done beforehand.
Yeah.
And then it depends on what's been done. If someone's had an attempted full resection, then it can be difficult to see what's being done. But they will advise you what operation has been done, and you can compare that to what operation you would have done with those pre-op imaging. And in this situation, sometimes you do need to do mapping biopsies. So you need to go in and try and figure out what's going on. But, you know, in this case here, if someone had done a resection of this case without taking the lamina, without taking the cribriform plate, then we would go and be doing that procedure. You know, we're not going to leave this patient without having done a clearance on them, because even your mapping biopsies mightn't show any.
Right. So what the panelists are trying to say is that if the patient comes to you and he has been recently operated, it becomes a challenge to evaluate what has been left behind. So we need to look at the previous scans prior to the surgery and then consider what you would have done if you had known this was a malignancy and not a polyp. And if the surgical resection has not been adequate, then most of the panelists agree that you would go ahead and do a complete resection and then follow it up with an adjuvant therapy. As Ben said, these multiple biopsies being done to evaluate whether there has been a completeness of resection are not reliable. So you would want to consider doing a complete resection based on where the tumor has extended and then follow it up with an adjuvant therapy. Okay, so my question to you now is that having known that this patient has a Heinz 4 or an SNEC high grade, would your panelists consider neoadjuvant chemotherapy in this patient?
Yes, I like to do start the neoadjuvant chemotherapy using the cisplatin and edoposil.
And why would you do that? Why is would you then do it in all resectable tumors as well?
If this patient has the no operation, so we like to start the neoadjuvant chemotherapy. But if the tumor imaging that has no region the tumor, so maybe I'm not sure the injection chemotherapy.
So in your institute, you practice neoadjuvant chemotherapy as a protocol?
Yes. Usually we use cisplatin and edoposil. Edoposil.
Right.
Right.
What about the other panelists, Krishna Kumar, Ben?
Yeah, Prathamesh, for this case, we would not probably consider neoadjuvant chemotherapy. When we consider neoadjuvant chemotherapy in esthesioneuroblastoma with two intentions and two situations. That is one for orbital preservation and the second for the skull base or the dural preservation. So if there is a borderline involvement of the orbit, and if straight away if we go for surgery, that will lead to an orbital accentration in such situation. Or if we want to preserve the dura, we want to avoid like a craniofacial resection. In such situation, we may consider neoadjuvant chemotherapy to shrink the tumor and then make the tumor resectable. Follow it up with the concurrent chemoradiotherapy.
Ben, what do you practice?
Yeah, look, I'd agree. This is a young guy that to me looks eminently resectable. I do want to see whether it's going into the orbit, but on the ones you give me, it looks as though it's resectable. I do want to see what's happening in that sphenoid and the posterior ethmoid, but almost certainly in this case, we would offer them an endoscopic resection.
Yiming, you want to ask anything?
Sorry?
No, Dr. Yiming. Yiming, any comments?
In our center, we have a multidisciplinary team. This patient looks to me is still resectable, but the tumor is quite close to the orbital apex here.
Okay.
So we may have a discussion with the radiologist, radiotherapy doctors, and the medical oncologists.
Right.
I think maybe a new adjuvant chemotherapy can help us achieve negative margins better.
Okay, so what the panelists have raised concerns are manifold. One is that this is a high-grade tumor with lymph node metastasis, and this patient is young and has a potential for distant metastasis. There's a concern about the orbit being involved and the ability to clear it completely. And in those cases, you might consider neoadjuvant chemotherapy. Sarbani, would you want to add anything?
No, I don't think so. And the other thing that we have to remember, this patient also is a Hyams grade 4 possibly and has a level 1B lymph node metastasis.
Yeah. So what we practice in the institute is for high-grade tumors, we would consider neoadjuvant chemotherapy. Unlike what KK said, that in case you want to avoid opening the dura or the orbit, now we have moved away from the practice where we were concerned about resectability and orbit preservation to doing it as a protocol in these patients because of the potential for a distant metastasis, as well as the possibility of a better control rate. So the house is divided. There are surgeons with good experience, with like Ben, who would do a complete resection and then give adjuvant therapy, whereas some of us would also practice neoadjuvant chemotherapy. As has borne out in the collaborative study, there is no defined role as yet, but I guess over time we will see as the data matures as to whether it's actually benefited in the local recurrence-free survival and the overall survival. So let's move on. I would like to ask the surgeons, what would be your surgical plan for the primary and the neck? I'll start with Ben.
Yeah, so as I said, endoscopic resection, the cribriform would come out, the dura would be resected and reconstituted, the lamina comes out, probably the periorbiter in this case, and as long as the PET-CT scan showed no disease in the other neck, we'd just do a one side, and the post-operative radiotherapy would take care of the contralateral neck.
So
reconstruction would be.
Yes.
Reconstruction would be with a contralateral nasoseptal flap, or if it looked as though it invaded the septum, then we'd harvest a pericranial vascularized flap and put it through a post-office osteotomy in the nasal bones.
So Ben, how would you evaluate the orbit for resectability? If there is a concern, like you're seeing the central image having a diffuse involvement of the lamina possibly going in through it into the periorbita, how would you assess it? Would you do it intraoperatively, or would you have considerations of consent being taken for an exenteration?
Well, I think if you've got a consent for an exoneration, then I would be going for neoadjuvant radiotherapy, neoadjuvant chemo to start with. So I'd have to be fairly confident on the CTMR that I could get it out. The way we do ours is we debulk these tumors, the air tissue interface, we just debulk it. Air interface we debulk, and then we look for the tumor tissue interface, and we stop when we get to that tumor tissue interface. And in this case, we would access the lamina anteriorly and crack it out, and then have a look at our periorbiter as it goes back to see whether it is not involved at all, or if it is involved, we would then open the periorbiter at the start, push the fat to the side, and have a look to see whether it comes through the periorbiter or not. Right. And in that situation where it did come through the periorbiter, having not consented the person for, I don't think I'd still take the eye. You know,
Right.
if it's even a little bit, I wouldn't take the eye. We'd give them the radiation and we'd keep a close eye on them and do an exoneration if it ever occurred in that location.
Right.
Which is
Professor
different.
Yoshimoto? Sorry.
Which is
Go
different.
ahead, Ben.
If we do operations, so my concern is periosteal invasion and around the periorbital area. And then if we do the surgery, we always check the posterior periorbital merging by frozen section. And then we have to get the negative merging of the periorbital. So, but after the injection chemotherapy, probably the tumor so shrink and probably easy to preserve the periorbital, but so we have to take care. And then finally, so maybe if the tumor very good response after the injection chemotherapy, I think it's we don't have to do any operation. Probably CCRT is better for the primary site, I think.
So you would do a endonasal resection and assess
Yes,
the
if we
periorbital.
do the operation, the endonasal is enough. But so I think my concern is the periorbital invasion. So if we do have to the more periorbital region, so maybe the reconstruction by the for example the fascial router reconstruction is better for the orbital position. Yes, so that's why. So I think that the periorbital image is very important for the checking the periorbital area.
Krishna Kumar.
Yeah, I would agree to what was already said. This tumor is probably amenable to an endoscopic endonasal resection, and we may have to clear the periorbita under frozen section control. Most of the times we would get it. That's what I feel. Of course, if there is significant involvement, we would have taken the orbital consent. And neck dissection, usually this selective type of neck dissection of the involved nodes and reconstruction with the contralateral nasoseptal flap, or if that is not available, we may go for a pericranial flap, which we have often harvested again with the insertion and scope.
Right. So everybody is focusing on the endonasal resection. I would like to ask, what about the dura? And especially since it's an esthesioneuroblastoma, would you not be concerned of removing the olfactory bulb unilaterally? What is your take and philosophy on resecting the olfactory bulb, even when there is no direct involvement of the bulb in an esthesioneuroblastoma? This is like, if you looked at the Kaddish staging, this would be a Kaddish B. So then would you all do a subcranial resection, or would you then consider doing a removal of a unilateral olfactory bulb in this patient?
Yeah.
Ben?
Yeah, so I need to have a good look at the MRI to see how close that goes to the cribriform plate.
Right.
And I'll have a low threshold to take that cribriform plate and the olfactory bulb out, because I don't think there's any issues with reconstruction. In that one, I wouldn't take the whole of the cribriform plate, and I would not take the contralateral olfactory bulb, because this looks quite localized to that left side.
Okay. Professor Yoshimoto?
So I think also the tumor, depending on the tumor extent and the intracranially, and then even if we do endoscopic section and with dural resection by endoscope, but probably this case has need post-orbital radiotherapy. I think is finally the smell function is difficult to preserve, I think.
Okay. Yiming, any thoughts? Any questions you want to ask? You're muted, Yiming.
No more commentary. Thank you. I agree with them.
Okay. KK, you practice removing the bulb, or you do a subcranial resection in a caddish?
We don't usually, if it is not involved, we don't usually remove it. That's how we do.
Right. So
but then we restrict the involved dura, the bone, and go on.
Okay.
But yeah.
So what we have heard from the panelists is that the lesions, just because it's an blastoma, doesn't require to do an ipsilateral olfactory bulb resection. You need to study your scans carefully. You need to see whether they are really coming onto the olfactory filaments, and then consider doing a resection of the dura and olfactory bulb. You also need to understand that the patient's smell function is limited because you're removing the end organs, and you will follow it up with an adjuvant therapy. So let's ask our colleague Sarbani. We have considered doing neoadjuvant therapy, 1, and 2, doing surgical resection. Now, if I give neoadjuvant chemotherapy and there is a volume reduction, what are your considerations for follow-up radiation therapy in these patients?
Thank you for that question, Prathamesh. What I would do essentially in this patient is, at the baseline scan itself, an important thing to decide is whether this is just an external effect or is it actually infiltrating the optic nerve. If it is just pushing and it's just a mass effect, I won't be so concerned, especially if the patient has responded well. Because if you look at the coronal section, actually it doesn't look like as if it's going in, but then we may have to go a little bit more posteriorly to be very sure about whether it's actually going into the apex or not. If it is not really infiltrating the periorbita, but just abutting it, my job is easier. My considerations then would be to try and spare definitely the opposite optic nerve, but also the ipsilateral nerve as far as possible. I would take recourse to, during the planning, for fusing the pre-operative and the pre-NACT images with my planning scans, and also do a planning MRI to be doubly sure of the location of these critical organs. I would also involve the radiologist to be very sure that I'm contouring right. And then, of course, during the radiotherapy, I would take recourse to daily imaging, because that would help me reduce the margins around my primary tumor, but protect the ipsilateral nerve also. So these are the considerations for me as the radiation oncologist, because what I have to attempt to do is to have useful function in this optic nerve. I need to reduce or keep the doses within tolerance limits. So for me, it is important. So I look at the pre-NACT scans. I look at your per-operative findings. And then, of course, I would look at the scans together with my post-operative scans also. So these are three important considerations for me. And in addition, of course, the functional evaluation prior to initiation of NACT and post-operative prior to initiation of radiotherapy.
Right. The concern that we have, Sarbani, is that the patients will lose their vision following radiation because of the orbits being controlled or contoured in a way where the optic nerve or the retina is involved. So I think this point is very important, that if you give neoadjuvant chemotherapy or you're done a resection and preserve the orbit, it is the job of the radiation oncologist to contour it carefully so that the orbit and the optic nerve is not radiated. These were in the past wherein you would have to give, monoblock parallel opposing fields. But since you are going to use IMRT and you're going to use contouring techniques, which are now more precise, you would be able to actually save the optic nerve predominantly and avoid radiating the entire orbit. And this would be in the post-operative setting, so where there will be a change in the position of the orbit and the globe.
Yeah, and we would use image guidance during radiotherapy also. So that is what is very important, so that we know we are actually delivering what we have planned to deliver. Right. So that is again another very important concern and an important point to keep in mind. And evidence does show that with the adoption of these techniques, we have been able to reduce radiation-induced optic neuropathy to almost 50% of what was being reported with the conventional era.
Right. So I think these are very important considerations when we have a case where they are in close proximity to the orbit, and you would do a surgical resection following it up with adjuvant radiation therapy. So this case was put up in our multidisciplinary clinic, and the decision was to give neoadjuvant chemotherapy for concerns of the orbit. And in these cases, the patient received cisplatin and etoposide. Patient received 4 cycles, and this is the post-op imaging. You can see that the tumor has now reduced considerably in the nasoethmoid region. There's a complete shrinkage and delineation of the periorbita. And what we are also seeing is the tumor shrunk away from the dura as well. So there's now no longer much concern about the the dura being involved. Now I would like to ask the surgeons, what would you now consider? Would you do surgery or would you give chemoradiation? Now, bear in mind, this is a high-grade tumor. You've got a very good, it's a partial response, and the patient is symptomatically better. The orbit is spared, the dura is spared, and this seems to be a very good response. And when you look at the pathology, the radiologists, they're telling me that this just looks like some necrotic tissue now. And the PET scan done now I couldn't put that up, unfortunately, but there's a very low grade uptake on a PET scan. I'll ask first, Sichi, how would you practice? What would you do in your practice or in your institution?
We also have the multidisciplinary conference, and so probably it's a hard discussion between the surgeon and the medical oncologist and the radiation oncologist. Probably this response is very good, but I think the medical oncologists like to do the chemoradiation. But also the surgeon is we are able to the endoscopic minimum invasive surgery. I think the surgeon is like to do this the minimum invasive surgery using the endoscope. I think it's sometimes we do the operation sometimes with the chemotherapy, but basically this pathological pattern is we have the good response of chemoradiation. So in our experience, finally we like to choose chemoradiation for such a patient.
Okay, Ben.
Yeah, so the question always in my mind is, do you really need to go back and resect the original margins or not? And so this person would get an endoscopic resection, but to what extent we would debate in our MDT. And to me that, so this is not based on evidence, but to me that looks like a good response, and it may be that you've got necrotic tissue there. So in this case, I probably would just be resecting it as an endonasal procedure. I would not resect the cribriform plate, and I would not resect periorbiter in this case. And then they'd go for chemoradiation after that.
Okay, Krishna Kumar.
Yeah, I would also agree with that. I'll do a resection followed by chemoradiation, and the resection may not be that extensive considering the initial margins.
Yiming, any questions, thoughts?
No questions. I think the neoadjuvant chemo shows quite good effect. So it indicates that the CCRT might also have a very good effect on this patient. But I think during the multidisciplinary discussion at our center, I, as a surgeon, will consider an endoscopic operation first to get a more detailed pathology, and then the patient goes to radiation post-operatively.
So, Bunny, how would you discuss this in your joint clinic?
So Prathamesh, as you know, in this case, we would consider doing endoscopic surgery, a resection, followed by adjuvant CTRT. So I would agree with the other panelists also on this.
Right. So as Ben said, there is no evidence currently on how to practice or go ahead the house is divided, and even in literature we find that, like Professor Yoshimoto said, certain entities might consider chemoradiation. And there is a strong group from Italy which looks at the undifferentiated and neuroendocrine. And if they define it more than 80% response would go in for concurrent chemoradiation upfront. And because they have seen that almost 80% of them have a complete pathological response. So we do not know what is the right way ahead, but in our institute, we would practice doing like Ben said and Krishna said that we would do, and Yiming said that we would do a minimal endonasal resection, clear the ethmoids and the lesion right up to the skull base, and not enter the dura, not enter the orbit unless required, and then follow it up with adjuvant therapy. So the question to you, Sarbani, is if we needed to now give adjuvant therapy, what we would do for adjuvant therapy? Would you give just radiation or give concurrent chemoradiation?
Again, because this is ENB HIAMS 4, I would consider giving concurrent chemoradiotherapy rather than adjuvant radiotherapy alone. And do you want me to talk about the radiotherapy volumes?
If yeah, sure. There'll be some radiation oncologists, I hope, listening to us.
So I would definitely cover not only the primary disease, but I would also cover the neck node that was involved, because I assume that you would have addressed this. I would definitely treat the involved lymph node, and I would also give some kind of elective nodal irradiation to the level 1B and to the level 2 also on this side, because I see in most of the cuts, at least I'm not seeing any kind of it crossing the midline. But then because it is occupying the ethmoids and the nasal cavity, I am actually a little, I would tend towards doing even elective contralateral radiation, at least of the 1B and 2. That's what I would do, because it's involving the posterior ethmoids too.
Okay, so we would, as surgeons, address the neck at least ipsilateral, and if there are multiple level nodes, we would consider doing a bilateral neck. And then follow it up with adjuvant chemoradiation. So the point brought about is an elective nodal irradiation needs to be considered even on the contralateral side because of the possibility of it being crossing midline. I guess that would, does PET-CT help in this, Sarbani, in any way?
So the baseline PET-CT would have actually helped me knowing the extent of nodal disease, if at all, but not for my radiotherapy planning. I would not use it for radiotherapy planning.
Okay. So any other thoughts on this, Iming, or we go to the next case?
Prathamesh, what happened to the neck nodes after the neoadjuvant chemo?
So the neck nodes also responded. In this patient, the neck nodes completely vanished. And this patient we did the endoscopic surgery and the neck dissection. And there was a pathological complete response in the neck nodes. There was a minimal residual disease in the ethmoids. And this patient went on to have chemoradiation thereafter. And Sarbani, of course, even radiated the contralateral level 1B and 2.
Yeah, so if we had a complete response in the neck, we wouldn't have done a neck dissection, and we would have just gone on to chemoradiation for the neck and the contralateral side.
Right. So there was a light up on the PET. It didn't go completely on the PET, but on the pathology, there was a complete pathological response. So maybe, the low grade activity seen on the PET, but it didn't completely go.
If the PET was suspicious, we would have done a neck dissection.
Right.
It's we only believe in PETs if they're negative.
Right. This is from your trans-Tasmanian study as well, I guess. So you can draw a parallel from there, wherein if you have a good control in the neck on PET scan, you have a negative predictive value of more than 95%. So I guess we can draw parallels from there and not consider doing an elective neck dissection. Okay. So we'll go on to the next case. So the next case is also a lesion, an esthesioneuroblastoma. In this case, the lesion is a Kaddish C. It is having bilateral intracranial extension, and it is still not going into the periorbita. So this has come as a Himes grade 2 and is a tissue neuroblastoma. So I would like to ask the surgeons what they would do. Again, Sarbani, your comments on whether this patient should receive neoadjuvant chemo. Let's start with Krishna Kumar.
Yeah, I think in this patient, we would definitely consider a neoadjuvant chemotherapy followed by surgery and then adjuvant treatment.
But why would you do that? This is an eminently resectable lesion, not much of an intracranial extension, not involving the brain. There's intracranial extension. There
Okay,
are no.
Okay, I thought it was involving the dura and.
It's involving the dura, but there is no parenchymatous involvement, no brain involvement as such.
Yeah, as I said before, we have a concept of like, trying to avoid dural resection. So in esthesia neuroblastomas alone. So in such cases, we would consider neoadjuvant and then considering like organ preservation type of approach.
Okay. CG, what would you do?
So the tumor will embed into the intracranial area, but probably it does not embed in the brain. So I would like to consult the neurosurgeon, and then so if the neurosurgeon would so think we don't have to do the open approach, so we like to do the endoscopic approach alone, but neurosurgery is a controversial. So finally, if we do the open approach, but probably maybe the induction chemotherapy is one of the choice because this patient is very young, and I think the response is not so bad. So if we do the open approach, so I think that after the induction chemotherapy, maybe that we can do the endoscopic approach alone. So I think it's a consult after the consulting the neurosurgeon.
Okay, Ben.
Yeah, that's a difficult one. It's low grade, so it's not going to respond as well to the neoadjuvant chemo. Young person, so that's what we'd debate, whether we give neoadjuvant chemo or proceed to surgery. My gut feeling in this case, because I think there's no intraparenchymal invasion, we'd go for an endoscopic resection initially.
Okay, Yeming, what would you do?
We will do a surgery with a neurosurgeon first, and then we will have a adjuvant therapy.
Okay, so I guess this is a slight difference from the earlier case, wherein though the extent is a Kaddish C, the grade of the tumor is low grade. So as Ben said, the possibility of response is low. The patient doesn't have anything. We have got a PET scan on this, and there was no nodes, there was no distant metastasis. So in the joint clinic, the decision was to do a surgery followed by adjuvant therapy. So CG said that you do an endoscopic resection in consultation with the neurosurgeon. What is the decision making that you would do when you decide whether you do an endonasal approach or will you do a transcranial approach for the superior control?
Actually, in fact, I do not any the endoscopic operation. So we have the many young excellent endoscopists, doctors. So we ask them to decide the features better. So I don't have any experience as an endoscopist, and so I'm not sure that this is okay or not with the endoscopic approach alone. So, but probably this tumor look like it doesn't embed into the brain itself. So
any considerations for a lateral extension or a superior extension that would then preclude doing endonasal, or then you would go definitely for a transcranial approach? Krishna, you would like to?
Yeah, in this case, I don't think there is much lateral extent if the tumor is going laterally beyond the mid-pupillary level, or anteriorly if it is involving the bone, nasolacrimal system, or the skin, then we may have to consider open approach. But here, probably an endoscopic approach would be enough, and neurosurgeons' help may be required in getting out the tumor from the dura and brain area. But probably it could be done from the nose itself with neurosurgical assistance.
Ben, what would you do?
It seems very midline, so I'd be happy to, do an endoscopic resection, and we have the neurosurgeons on standby, but the ENTs would probably do this one by themselves.
Okay, so this is the next question I'd like to ask the surgeons. Do y'all do it? If there is a gross parenchymal invasion of the brain, would that be the only indication for getting a neurosurgeon on board? Or would you then get a combined team of a neurosurgeon and ENT to do this surgery? And what would be a recommendation for the audience? Ben.
Yeah, so we work with our neurosurgeons when we do the open craniofacials, and when we do the endoscopic ones, they're available. They'll pop into the room, so that they're there. But we tend to do most of it. We'd get involved if that's right, see that, and so we get them involved if we're going to start to resect brain. But that's pretty uncommon because you can usually pick that beforehand. And in this case, there's a nice white line, between the parenchyma and the tumor. So I doubt whether you'd need to take it. It'll peel off easily, this one, I would have thought.
Right. So, CG, would you always do it with a neurosurgeon, or you would then, like Ben said, call them and only when is required?
Even if we do the endoscopic resection around, we usually ask the neurosurgeon to have to back up the support for the operation.
Right. So, Yiming, what do you all practice?
We will do an open surgery with the neurosurgeon. If the tumor involves dura, we will always call a neurosurgeon to help.
Okay. So I guess these are varied practices, but most centers practice a combined approach with a neurosurgeon. So if it is a gross intracranial extension, which is going beyond midline, you would want to do a transcranial combined approach, a transcranial resection along with an endonasal resection. If it is paramedian and it is not going into the brain parenchyma as much, you would then consider doing a transnasal craniectomy and resecting this dura from the nose. So both the approaches are valid. You need to evaluate how much is the extent laterally, because you need that margin on the dura. The clearance from the arachnoid or the brain is similar to what you do with an open approach, because you're not going to take large bits of the brain out. You're going to do a limited resection in close margins to the tumor. But yes, you would necessarily require the neurosurgeon as a backup. In most cases, the neurosurgery and the ENT would work as a team to do this surgery. So we have all agreed that we will need to do an endonasal or an endonasal assisted resection in this patient. So now it comes to the defect in the cribriform. How do you reconstruct that defect in the cribriform if you do a transnasal craniectomy? Ben?
Yeah, so initially we'll look to harvest a nasoseptal flap, and this one looks quite high in the nose. It looks to be going to the right side, so I would expect there would be a good nasoseptal flap on that left side. It may need to be taken a little bit lower and down onto the floor, and it certainly has to be taken right up to that mucocutaneous junction, because it has to be bigger. If there's any problem with that flap, I think it's pretty easy to harvest a ipsilateral post box at the front, and we'll just tuck it in from there. That's the reconstruction from below. So to start with, we'll put our our Duragen in our tensor fascia lata, we'll do that as an inlay, and then we'll use whatever local vascularized flap we have to do from below, and then pack it up from below with some nasopore fort.
Right. Sichi, how would you all practice this? How would you close the defect?
Oh, so for reconstruction of the dura,
yes,
probably they're using the fascialized style and the 3 layers, and they're using the pedicle, the nasal septum, and I think that we know how to use the orbital pericranial flap.
right.
Only the nasal flap is okay.
Okay. Krishna?
Yeah, the reconstruction would be like two layered. The first of all, we have to consider the dural defect, and for that we do a layered closure, usually with a Duragen inlay followed by fasciolata inside and outside, and then we have to provide a vascular support from below. That is usually in this case a pericranial flap that has to be harvested and tucked in through the frontal sinus, I guess.
Right. So we have heard from the panelists that the defect here in the skull base is about 3 to 4 centimeters, and the defect of the dura can be reconstructed either with nasal septal flap along with the facial lata if you have the possibility of a nasal septal flap. If it is like this case where both the sides of the nasal septum would be involved, you would want to consider doing a facial lata repair. And if you are confident of doing a pericranial flap and taking it down through the frontal sinus, making an opening in the frontal sinus, that gives a very good, robust repair. Most of the data that has come in the endoscopic literature supports the use of 2 to 3 layers of facial lata, and the CSF leak rates are extremely low to the tune of about 3 to 5%. So I think the endonasal repair along with the facial lata is valid, where there is no possibility of the nasal septal flap. But if you have a possibility of doing a pericranial repair, that would give a very good support. The use of Duragen and facial lata has come up in the last few years as a standard of care. So I think it remains to be seen if there are any other ways of doing repair of the dura. There have been some surgeons, especially from Japan, where they are now discussing the role of endonasal sutures being placed to repair the dura. But I guess that is more technical and technically demanding, and in time to come, we will see how that comes into fore. Sarbani, any change in your planning of radiation for this patient following our resection? When would you start radiation? Now we have bared the entire skull base. There is a denuded of the mucosa. It's not like a functional endoscopic surgery. Most of the skull base will be raw bone and will be covered with some facial lata, or maybe if there's a pericranium.
So essentially, Prathamesh, in this case, I would look towards the surgeons to tell me that the patient is ready to start radiotherapy. But extrapolating from the other head and neck sites, I would prefer to start radiotherapy within about 6 weeks of surgery, provided the wound has healed adequately and the surgeon feels that the patient is going to be able to tolerate radiotherapy, because I do not want to stop the radiotherapy in between or any kind of leak or anything of that sort. So that is my contention. So I would like to start it within 6 weeks, but provided the wound has healed completely.
Okay. So this is what we did. We did a complete resection. We found that the tumor was just reaching the arachnoid, and we could get that tumor off the arachnoid very well, and got a good clearance and had a complete resection of the fox as well as both the olfactory bulbs. And then a 2-layered facial lata repair was done. And this is the post-op wherein we're seeing a very good healed mucosa. So now let's go to the third case. I think we have time for a third case before we go on to an external canal. I want to really pick on Ben's thoughts on the external canal because they got one of the largest series in the world on this. This is an intestinal type 46-year-old patient with a tumor in the nasoethmoid region. And the intestinal type on IHC is positive for CDX2 and CDK20 and negative for CK7. And it shows a P53 wild type. So I would like to ask the panelists, would they do a neoadjuvant chemotherapy in this patient or consider doing a complete endonasal resection following up with radiation, if at all? Ben?
Yeah, again, it depends if I think I can get it out easily with a good margin. So it's intestinal type, it's P53, so it should respond well to chemo. That to me, on that scan, looks a little, looks pretty close to that inferior orbital fissure, extending back onto that lateral wall. So, it just really depends on the CT, the MR, good quality. If I think I can get a good margin around it, I'll go and resect it. If I'm in doubt, then I would consider neoadjuvant.
Okay. Sichi, Yiming?
Yeah, we don't have many patients with adenocarcinoma in Japan. But so this tumor is so small, but the location is a very bad side. So I think it's generally the adenocarcinoma is difficult to have the response after chemotherapy. But this type is not so bad. So no, we like to do the induction chemotherapy before surgery.
Okay. Krishna and Yiming?
As far as we are concerned, our experience with this adenocarcinoma intestinal is very less. For some reason, we don't have this wood exposure and adenocarcinomas. It's not very commonly seen. But having said that, in this case, probably considering the orbit, we may consider induction chemotherapy.
Yiming, any thoughts?
I think this one we will operate first and then do adjuvant therapy.
Okay. So as Sichi said and as Krishna said, we rarely get these adenocarcinomas of intestinal type, and we are in our whole series. They form a very small population, and amongst them, almost 40% are only P53 wild type. So having understood the response to the wild type P53 in ITACs from the Lisa Lisitra's group, we do practice neoadjuvant chemotherapy, as Ben and Yiming said, if they are looking reasonably advanced, coming onto the tegopalatine, coming onto the inferior orbital fissure, or coming onto the dura. In the others, if there is a complete possibility of a complete resection, we go ahead and resect it completely endonasally. And then following up with radiation if we have got margins positive. We do not, radiate all our ITACs if we have got a negative margin or they are T1, T2 tumors. Sarbani, do you agree with this?
I do agree with it based on the limited experience that we have with P53 wild type. I would rather send NACT.
Right. So for the audience, please read these papers from the Italian group, and we need to get our pathologists to do the P53 analysis on these patients because they do not do it routinely. And if you have cases which are advanced and coming onto the dura and the orbit, as we saw in other cases, you should consider doing neoadjuvant chemotherapy because they have a 40 to 50% chance of a pathological complete response. And those that have a pathological complete response have 100% disease-free survival. So these are good prognostic markers, and we should use them in our practice. So the last case for the day is a 60-year-old male who has a left external canal growth since 1 year. He has no facial nerve paralysis, and he has its biopsy proven as squamous cell cancer. There is no facial asymmetry. The patient has no vertigo or imbalance and no headache. On imaging, when we did the high resolution CT scan, we find that there is a mass in the external canal, and it seems to be limited to the external canal. There is some concern about it going posteriorly onto the mastoid and coming onto the middle ear. But the scans do not show any involvement. We did an MRI, and the MRI showed that there was a mass in the extrinsic canal. The mastoid was full of inflammatory tissue, and the middle ear itself was not involved. So you could see that the middle ear structures and all are completely free of the disease. Inner ear structures are free. So in a case like this, how would you plan the treatment, Ben?
Yeah, so it's interesting. We've got a large experience with temporal bone carcinomas, but only 10% of ours are primary external auditory canal. Most of ours extend cutaneous malignancies, right, which extend to the temporal bone. But this looks like a T2. So this, so they'd get the standard workup with the MR and the PET-CT. I'd want to know if there's any nodes in the neck. If the neck was clear, this person would get a lateral temporal bone with a superficial parotidectomy, and the closure would probably be just temporalis muscle rotation flap to close, and they would get post-operative radiation.
Okay. CG, how would you all manage? Yeah, Ben, go ahead. Ben?
So the post-op radiation would cover the surgical bed, but would also cover the upper neck.
Okay. CG?
Oh, it's very difficult to do the what kind of surgery is the best for this patient, and I think that always we check the how far the tumor is from the jugular vein, sigmoid jugular vein, jugular fossa. So I think the tumor very close to the jugular vein in there. So it's difficult to ligation with the jugular in the operation. We sometimes we like to do the concurrent chemoradiotherapy using the 3 drugs, cisplatin, 5-FU, docetaxel. But this case is so method the selection, but so a little bit not so close to the jugular vein. I'm not sure that this we need more details of the MRI.
Okay.
More details wise.
Yes. The jugular was free, CG. The jugular was free. The middle ear was free on imaging. There was mastoiditis in the mastoid, which was looking as though it was involved on the CT scan. But clearly the tumor was only in the extrinsic canal. Okay. Even there were no parotid lymph nodes either on the MRI. And the patient had a normal facial function.
Maybe this tumor not embedded into the middle ear.
Yeah, not in middle ear. Yeah.
So probably the lateral temporal bone resection is possible, and using preserving the facial nerve. But so I'm not sure that actually the preserved facial nerve is okay or not. So I'm not sure, but basically is maybe we can preserve the facial nerve.
Okay, Krishna.
Yeah, I would also agree with the imaging would be initially an HRCT temporal bone and then an MRI to look for any middle ear involvement or any deeper involvement. And if since this case has no middle ear involvement, probably a lateral temporal bone resection would be enough, preserving the stapes. And yeah, reconstruction is probably a temporalis also.
So Sabani, would you always radiate these patients?
So from our own data that we've published, we realized that the best results are obtained with surgery followed by adjuvant radiotherapy. But for some reason, if this patient were not a candidate for surgery for other comorbidities and things like that, then perhaps we could definitely consider doing radical RT with or without concurrent chemotherapy, because I assume this is a squamous carcinoma.
Yeah, this is a squamous cancer. No, so my point was in a T1, T2 extrinsic canal, when we have done a lateral temporal bone, we have done a complete resection, there are no neck nodes. Would you then consider giving adjuvant radiation therapy in all these patients? That is the moot point.
Yes, we would, except for those very early mucosal external auditory canals. But for other lesions, we would definitely end up giving adjuvant radiotherapy.
Right.
Because again, from our own series, we know that the ones who didn't receive also recurred. So it's better to combine the LTBR with adjuvant radiotherapy.
Right. Yiming, any comments?
How about the function of the facial nerve after definite radiation?
There is no problem because we would not actually go so close, and plus the doses that the facial nerve would receive would not be high. So we would not see a facial nerve dysfunction after adjuvant radiotherapy. And today we would use again IMRT with IGRT. So even the large vessels like the carotids would be out of the radiotherapy field actually, or the doses would be within acceptable limits. So I don't think we will cause a problem there.
Okay.
Great.
Last 5 minutes. We have this case where this patient again is 58. He has a lesion in the external canal. He has no facial nerve paralysis. And you can see here that now the lesion is not just limited to the external canal, it is coming into the middle ear as well. So we, as a routine practice, we also do an MR with a venogram to assess these patients. So this was the MRI, and it showed more disease than what we expected on the scans. And the sigmoid sinus was free, the inner ear was free, and there was no there was this node or involvement of the parotid anteriorly. So for the surgeons, I would like to ask Ben, how would you practice treatment of this patient?
Yeah, so the dura is clear.
Dura
Dura is clear, and then you want to match it off the jugular bulb, because if they're into the jugular bulb, the survival 1 year is 0.
Right.
So those ones that have dural involvement, jugular bulb involvement, stuff like that, we'd give them cemiplimab. But this one here, if that's all clear, again, this person would get a temporal bone excision, parotid, and an upper neck, probably with a free flap reconstruction. So the question you're really asking is do you do a lateral temporal bone, or do you do a near total temporal bone? And this person's facial nerve is normal, isn't it?
Right.
Yeah, so I'd be doing a lateral temporal bone, and the tumor that has invaded into the middle ear space, hopefully we can just lift it out. I'd be reluctant to want to take his facial nerve.
Right. I think this is the point that is of concern, that when the patient has an intact facial nerve and there is no intracranial extension, no Peters apex involvement, then how far would you go ahead and do an R-block resection versus doing a sequential resection following a lateral temporal bone following the pathway of the disease? So this is something that we are practicing for the last few years, and we know that the disease really doesn't confine itself to the temporal bone like in a subtotal temporal bone resection. So you would rather do a sequential resection if the patient has no facial, no jugular bulb involvement, no dural involvement. In those cases, you should consider doing a sequential resection, because your endpoint would remain the same. You would take off the parts of the bone involved and preserve the parts of the structure, the brain, the dura, the jugular bulb, and all which are not involved. So I guess we all are in sync with that kind of a resection today, and the outcomes following a resection of a subtotal temporal bone would be more aggressive. You would necessarily have to resect the dura, resect the part of the facial nerve. And though you get a nice specimen, this is not something that might help the patient in the long run. So I guess we are done with today. I would like to thank the panelists for an elaborate discussion and bearing with me. And I hope you all have had a good time. I hope the audience have had a good learning experience. And if there are any comments, please send it to us on email, and we'll be happy to answer you.
So thank you, Prathamesh, and thank you, panelists. We have the questions posed by the delegates in the chat box. So next 15 minutes, you can take those questions, Prathamesh and Yemi. It is there in the chat box if you go.
Okay. Yeming, would you look at the chat box, please, and ask the questions if possible?
First question to all the estimated panelists. So if there's no gross disease on nasal endoscopy, to wait for 6 to 8 weeks and then a PET to get better information. If there's obvious gross disease left behind after the recent surgery, then we needn't wait and go ahead with the PET, even if it's just been 2 weeks since the surgery. Is that correct?
We don't usually go for a PET, but we may wait for 6 to 8 weeks and do a repeat MRI to see the extent of the disease.
But should be preceded by a mucosal examination.
Yes, it should be. And if preoperative imaging, good imaging is available, we would resort to that too.
Okay.
Okay.
Ben?
To
Yeah,
Dr. The first case. Hi, Professor Ben. What are the options of base of skull reconstructions for this case?
Yeah, the question's been answered.
Yeah, I think so. Then to Dr. Pai. After NACT and ACT, if there's a PR or CR, then shall we consolidate it with the concurrent chemoradiation?
I guess the panelists have answered that, and the literature is divided. There are a group of people who would consider giving concurrent chemoradiation, but most surgeons would consider doing a limited resection of the residual disease and following it up with concurrent chemoradiation. Of course, you should not increase the morbidity to the patient and do a dural resection or an orbit resection, because that would necessarily not help the patient, because there's already been a good response to the chemotherapy.
Prathamesh, I have a point question to ask here. Probably you or Sarpani can answer. What would be the best neoadjuvant regimen for chemo, depending on the pathology? Is there a variation?
I think it's histology driven, because as Sichi also said, esthesionoblastomas and the sinoneural endocrine tumors seem to respond to cisplatinum and etoposide. That seems to be the preferred chemotherapeutic agent. Whereas in the adenocarcinomas, they would prefer giving cisplatin with 5-fluorouracil, or a combination of now the newer ones like the Folfox if it's an intestinal type. So it is not, since there are few cases being treated with this neoadjuvant chemotherapy, the chemotherapy regimes are varied. So we are also requesting the medical oncologist to not just give the flavor of the season chemotherapy, but give a standard chemotherapy for the cases which are few, and then at the end of few years we can assess. So we currently practice cisplatin etoposide for SNECs, sinonasal undifferentiated carcinomas, esthesionoblastomas, and squamous cell cancers. They would get a cisplatin, and for the others,
was that analyzed in your data? The response to different regimen, or
yes.
If not analyzed, is there a scope of reanalyzing the?
Yes, in the collaborative study group, the neoadjuvant chemotherapy has been used in a certain group of patients, and that's going to be analyzed. And we are also in midst of analyzing our patients who received chemotherapy.
Yeah. We can go ahead with other questions if there are any.
Okay, another question is for Madam Sabani. The role of definitive concurrent chemoradiation after ACT. I think Dr. Laskar has already answered the question in the chat box. So, no more questions.
Okay. Any last thoughts? I mean, everybody, please give us your pearls of wisdom for skull-based surgeries. Starting with Sichi. Any suggestions, recommendations to the audience?
Now, we need to get the recent collaborative data published. It's been sitting around for a long time.
Yeah, absolutely. Absolutely.
So the skull-based resection is to improve the year by year and the technique and but also that we had to be accustomed to the many new technique and using the endoscopic and also the the image diagnosis and also the pathological findings and also the many different pathological diagnosis and so we like to always consult with the pathologist and then so we like to make sure the correct diagnosis.
Right.
Yeah.
Ben?
Yeah, look, I agree. The pathologist is going to be super important with sinonasal cancer because the diagnosis needs to be accurate. And when people review their previous pathological reports, they have to change the diagnosis 20 or 30% of the time. So you've got to make sure that your treatment program is for the same disease.
Right. Krishna?
Yeah, I would like to just say that the sinonasal neoplasms are a challenging area, especially because of the varied pathology and because of which the collaborative efforts to bring in together the data is important to make meaningful conclusions and recommendations. So such efforts should continue. Yeah, thank you.
Yiming?
No more commentary for me. I'm just looking forward to the publishment of the collective data.
Albani?
I think in no other place in the head and neck is the importance of the multidisciplinary clinic truly reinforced like in the skull base. This really calls for a partnership between all the modalities, all the disciplines that are involved in the care of the patient. The pathologist, the radiologist, the surgeon, the medical oncologist, the radiation oncologist, and very importantly, also the rehabilitation is important in these patients, especially for the vision, for the hearing. We need to be careful about all these things also in our patients. Thank you.
Great. I think the audience has taken a lot of learning today, and I would like to thank you all for the excellent panel that you all conducted. Thank you very much. Thank you, everybody,
Thank
and
you.
in person soon.
Thanks a lot.
Thank you. Bye-bye.
Thank you, Pankaj.
Thank you so much, and I really appreciate the time you have taken. So we move on to we have 5 more minutes, and Gopal will be the one who will be leading the effort for the second session. And along with him, I have our Indian colleague, Dr. Dushyant Mandlik. So maybe Dushyant and Gopal can switch on their cameras and be available on the screen.
Good morning, Pankaj.
Hi, good
Pankaj.
morning. Do we have Gopal?
Yeah. Hi, Pankaj. Can you hear me?
Hi, Gopal.
Morning, Gopal.
Morning. Do we have Shekhar, all the faculty, the panelists? Can I request them to switch on their cameras so that we know that they are there? Perfect. So basically, we will start with the recorded lecture, which is the keynote address by Ivan Matros, and that will be titled as Immediate Dental Implants in Fibula Free Flap, Current Status and Future Perspectives. That will be followed by the panel discussion, which Gopal and Dushyant will lead. So over to you, Gopal and Dushyant.
Thanks, Pankaj. It's nice to be here and nice to see some friends online, albeit from miles away across the world. I think we'll get started since it's almost time. Maybe Dishant will start by introducing the first speaker, and then after that, we'll get on with the tumor board panel. Dishant, over to you.
Thank you, Gopal, and good morning to all. It's nice to see you, everybody here. Our honored speaker is Dr. Ivan Metros. He's from USA, associate attending surgeon and at plastic and reconstructive services at MSKCC. He got his plastic training from Harvard Medical School and microsurgical training from MSKCC. He holds special interest in breast and head and neck reconstruction following ablative surgeries, and particularly on the issues of quality of life. He is awarded Castle Connolly New York Magazine Top 10 Doctors 2018 through 2022 and has more than 100 PubMed Index research papers and citations. So I think with this, we can go to much anticipated talk of Dr. Evans.
As we all know, the fibula is the workhorse flap for bony reconstruction of both the mandible and perhaps the maxilla. This is because of its lengthy pedicle and robust vascular blood supply allowing multiple osteotomies. However, despite the benefits of the fibula flap, dental restoration in the head and neck cancer patient remains uncommon because of side effects related to radiation. The bone quality weakens over time from the radiation process, potentially leading to fracture. Patients with radiation are also unable to open their mouths as much, thereby limiting perhaps the benefit of prosthodontic rehabilitation. We also need sometimes to remove the plates following our radiation prior to dental implant placement, and this can cause delayed healing and wound problems. And finally, because of the bone stock being damaged from the radiation process, there may be limited ability for osseointegration. However, there remains an opportunity for dental implants to improve the quality of life for our patients, and therefore we think it is important to address. The conventional approach to dental implant placement is described here. A patient would undergo a fibula flap, and then at some point following radiation would have removal of the hardware to facilitate dental implant placement. The removal of the hardware is necessary to avoid interference between the osseointegrated dental implants and the screws that are placed for the rigid fixation. Sometime after the dental implants are placed, the abutments are exposed and a fixed retained permanent prosthesis can be mounted intraorally. This process often took many years to perform and many steps with an opportunity for complications at each step. In 2013, my colleague Jamie Levine at NYU described the concept of jaw in a day. This was reported in 3 cases of benign tumor removal in which an implant-retained dental prosthesis was placed and exposed at the time immediately following the surgery. Despite success in the benign scenario, no one had adapted Dr. Levine's workflow in the head and neck cancer patient population. Potential reasons for this are as follows. Unlike the benign scenario, in the head and neck cancer population, large intraoral excisions are often performed and the fibula skin island is necessary for soft tissue replacement. Exposure of the dental implants will require multiple puncture holes through the fibula skin island immediately at the time of surgery, risking compromise to this skin island. There's also concerns that dental implants will negatively impact radiation delivery through the creation of hot spots. Prior to undertaking our work of immediate dental implants, we performed a systematic review of the literature on this topic. It is clear that end-osseous dental implant placement is not only possible in the oncologic setting, but importantly, implants have a significant survival advantage when they are placed prior to the initiation of radiation. This informed our workflow at Memorial Sloan Kettering. Our thought is that all dental implants should be placed prior to radiation to improve the chances of bone healing around this dental implant. Next, I'd like to share with you our workflow, and I'm going to add in some technical pearls as we go through this. Our workflow for immediate dental implants is as follows. 6 to 14 days prior to surgery, an interdisciplinary planning session is performed with us, the head and neck surgeons, and the prosthodontist using virtual surgical planning. Intraoperatively, the tumor extirpation is performed with the cutting guides, and we elevate the fibula flap. We place a cutting jig on the fibula flap, and prior to making the osteotomies, we insert the dental implants through the slots shown at the bottom of the screen. 4 to 6 weeks following the fibula transfer, we perform in the operating room an intraoral vestibuloplasty and expose the dental implants. At this point in time, the fibula skin island is stable, can be thinned, and multiple holes can be punctured through the skin island without risking its vascular compromise. 1 to 3 days after the vestibuloplasty in the clinic, placement of a temporary prosthesis is performed. And then finally, after radiation, the final prosthesis is crafted. This patient is going to undergo a right segmental mandibulectomy and an anterior marginal mandibulectomy. The screen left shows the cutting guides for the segmental mandibulectomy, and the screen right shows a dental-borne cutting guide for the mandible, which is going to be used to facilitate the marginal mandibulectomy of the anterior segment. Here we can see on the screen left the guide adapted to the fibula and 2 dental implants placed into the turquoise segment. Anteriorly, there's a separate guide used to place the dental implants into the marginal mandibulectomy. When we do our virtual surgical planning for the fibula flaps, we always note the position of the septocutaneous perforator coming off the perineal artery. This tells us where the skin island is going to be used on the lower extremity, and then informs the segment of bone that will be used for the final reconstruction. We can then position the guide intraoperatively based on the location of the septal perforator and ensure that the shape of the guide matches the shape of the bone, and I'll show more of this on the next slide. This case highlights the concept I mentioned on the previous slide. If we were to use the bone positioned distally at 95 millimeters proximal to the lateral malleolus, the shape of the bone is quite triangular. However, if we use the bone that is more proximal on the lower extremity, the shape is more pentagonal. The important point here is that when you bring up the fibula jig and you adapt it to the bone segment, the trajectory of the dental implants is very important. If the guide is not designed specifically for that specific shape of bone, there'll be a misdirectional placement of the dental implants and unsuccessful prosthodontics. Here we can see the 2 cutting jigs fixed to the mandible. On the screen left is to perform the osteotomies for the segmental mandibulectomy, and on the screen right you can see the osteotomy necessary for the marginal mandibulectomy. This highlights some of the features of how we design our guides. You always want the guide to be centered on identifiable features. In this case, it can be the mandibular angle and a specific tooth root. However, posteriorly, sometimes to adapt a guide appropriately, there may be necessary soft tissue mobilization. So in this example, you might strip the masseter muscle off the ramus of the mandible, which could have functional consequences. More recently, we've moved to either using an intraoral scanner or taking dental impressions of the patients. We now use the occlusion as our preferred seating for all of our mandible or maxillary cutting guides. This allows us to minimize the amount of soft tissue stripping on the native mandible that will be retained, and also is more precise than aligning to structures such as the angle of the mandible, which cause slippage of the guide when making osteotomies. A similar guide can be seen on the maxilla fixed to the remaining dentition. Although we have all of this beautiful technology and you can plan a virtual surgical operation in advance, it's very important that it is executed with high accuracy and precision once you get to the operating room. Our mandibular guides and fibula guides have pre-drilling cylinders now, which can be punched out in advance. These holes on the native mandible and the fibula will align with the 3D printed plate and allow absolute precision and accuracy, which is of utmost importance when we think about dental rehabilitation. One of the biggest advantages of virtual surgical planning is not just the cutting guides, but it's the opportunity to design plates that are specific to a patient's anatomy. 3D printed plates will allow us the opportunity to take advantage of our knowledge of midface anatomy and the craniofacial buttresses. So when we design the plates for the midface, we make sure there are plenty of footrests of the plate where the bone stock is thickest at the nasomaxillary and the zygomaticomaxillary buttresses. This optimizes the extent of rigid fixation to avoid micromotion and ensures long-term healing of the reconstruction. Back to our case example. This demonstrates the fibula guide adapted to the piece of bone with the 2 slots for the dental implants. You can see this is drilled out by the prosthodontist prior to making the bony osteotomies. The construct is then brought up to the head and neck with the fixation plate already adhered to the bone. We then can inset the fibula flap, and here you can see 2 dental implants placed in the marginal mandibulectomy anteriorly. 4 to 6 weeks after the fibula transfer, in the absence of surgical complications, the patient is brought back to the operating room for vestibuloplasty. At this point in time, the fibula skin island can be thinned as needed, and then we puncture holes through the skin island to expose the dental implants. Protective caps are placed on the dental implants with a fixed prosthesis placed within the clinic in 48 hours. Approximately 48 hours after the vestibuloplasty is performed, the patient is brought back to the dental clinic for a temporary prosthesis to be placed. This is worn during the radiation process and then converted to a permanent prosthesis after all the soft tissue changes in the mouth have occurred. This is a final outcome for this patient, and you can see the Panorex at the bottom of the screen. Next, I'd like to share with you some case examples of patients in both mandible and maxillary reconstruction using this technique. This patient underwent a right hemimandible resection. You can see the fibula guide shown here with 2 dental implants on the screen right. This is the final outcome of the patient following her right hemimandible resection. In this instance, we used mini plates instead of a reconstruction bar, and we also performed an autocondyle transplant to maintain the posterior height of the ramus segment of the reconstruction. You can see the fixed retained prosthesis on the screen right mounted on the 2 dental implants. And this is a final postoperative view of her smile. This is a lateral mandible defect. In this case, there was an ameloblastoma. We opted to use printed mini plates for this patient in anticipation of future growth, as she was quite young when the reconstruction was performed. You can see the high degree of precision and accuracy that the reconstruction very much mirrors the virtual surgical plan. These are post-operative images of this patient. You can see the 3 dental implants placed into the fibula with nice bony union of the multiple osteotomies. There is some hair growth that remains on the fibula skin island. This is a large tumor involving the entire anterior mandible and will require an angle-to-angle resection, removing all of the lower dentition. A 3-piece fibula reconstruction was planned. Intraoperatively into the fibula jig, we place 5 dental implants into the 3 bony segments. For this case, a patient-specific printed reconstruction plate was used as opposed to an off-the-shelf product. A patient-specific plate will avoid any gaps between the plate and bone. This will ensure the prosthodontics align as intended in the pre-surgical planning. This is a pre-op photo of the patient. You can see the tumor involving the floor of mouth and post-operatively the skin island that was used for the vestibuloplasty. Note the changes in the mandibular height with the fibula flap compared to the preoperative photo. Let's next turn to some cases on the maxilla. I love this case because it shows the shortcomings of the freehand technique prior to the advent of CAD/CAM technology. This patient was operated on at another center for a right infrastructure maxillectomy and had a fibula flap many years ago. You can see the poor alignment of the single piece of fibula as it's positioned quite towards the midline. This precludes fixed retained prosthesis for this patient. The patient then came to see me with a new left-sided tumor, and we had a decision to make as to whether or not to remove the prior fibula flap or to leave it in place. In order to achieve complete prosthodontic rehabilitation of this patient maxilla, we opted to remove the right fibula flap and perform a left fibula flap, replacing all of the dental bearing segments. The screen left shows a clinical photo of this patient following his first fibula flap with his denture in place. You can see what's going on once the denture is removed. And then following his osseointegrated dental implants with his maxillary reconstruction following his second fibula, we can see a fixed retained prosthesis. These clinical photos nicely demonstrate some of the differences between the denture and the fixed retained prosthesis. With a denture, the patient has to wear a large device that is clasped to the remaining teeth. This patient specifically commented that people could notice this clasp when he smiled. With the fixed retained prosthesis, there's no additional metal within the mouth, and the patient can have a very natural smile and feel more confident. Let's look at this case of a infrastructure maxillectomy on the left. Traditionally, just about 10 years ago, we would use a soft tissue flap for this reconstruction, such as an ALT or radial forearm flap. More recently, though, with this technology, we're able to perform these reconstructions with bone. This is the same case in a young man with an adenoid cystic cancer of the right hard palate. He undergoes a limited resection, removing 4 teeth, and we are going to perform an infrastructure maxillectomy reconstruction with a single fibula bone segment. This slide demonstrates the unique shape of the printed plate specific for this patient's maxillary reconstruction. Thus, when insetting, we can be comfortable that the fibula segment is aligned in the X, Y, and Z axes. Importantly, this ensures that the prosthodontics are correctly aligned without any mismatch. And finally, it's important to note you can never hand bend a plate with such accuracy using traditional methods. This is a long-term postoperative clinical photo of the patient. We're able to do all of this with a limited incision over the facial artery and a limited lip split up to the right nasal ala. These are some long-term photos of him with his fixed retained prosthesis. You can see the fibula skin paddle is a little bit bulky intraorally, and of course there's an unsightly skin graft at his fibula donor site. Let's next look at hemimaxillary reconstructions. Traditionally, these were closed with a soft tissue flap that was bulky, such as a VRAM or a myocutaneous anterolateral thigh flap. This is another hemimaxillectomy defect, but let's see how we can do this in the more modern era with bone and immediate dental implants. This patient is actually the wife of an ENT pediatric surgeon. She had a previous sarcoma of the maxilla and underwent obturator placement without any formal reconstruction. Unfortunately, this patient's sarcoma recurred in the maxillary antrum. She's going to require a re-resection and completion maxillectomy on the left. These Panorex images show the patient prior to undergoing any resection and her current anatomy prior to undergoing the completion maxillectomy on the screen right. This slide demonstrates her existing anatomy with a planned resection, including removal of the body of the zygoma as well as the orbital floor, creating a complete hemimaxillectomy defect involving the orbital floor. This is a 2-piece reconstruction with 2 immediate dental implants using the fibula flap. Once again, you can see the 3D printed plate contoured to unique topographic features on the maxilla, including the anterior nasal spine and the sidewall of the lateral orbit. The precise position needed for the dental implants relies upon the plate as well as the 3D designed cutting guides on the fibula flap to make the correct angulation of the osteotomies. On the head and neck area, we have to complete the maxillectomy, and here you can see the dental-borne guide to make a new cut or osteotomy along the left parasymphysis of the maxilla, and a second cutting guide is positioned towards the zygoma. This case demonstrates the advantages of the fibula flap, but also highlights the importance of bulky soft tissue to obliterate surgical dead space. On the screen left, you can see the plate once positioned with the 2-segment fibula flap reconstruction. But importantly, a second skin island of the fibula is deepithelialized to obliterate the maxillectomy dead space. Once again, this is akin to the myocutaneous flap mentioned earlier, but now we've been able to do prosthodontic rehabilitation. This demonstrates the patient early postoperatively with a Panorex on the left, and once the dental abutments are converted to the final dental prosthesis following the vestibuloplasty. Here we can see the dental implants and the fixed retained prosthesis on the screen right. Clinical photos of this patient show some soft tissue atrophy over the left maxilla following the radiation completion, and she will need to undergo additional procedures, including fat grafting, to improve the cheek contour. This next case also highlights the chronic disease associated with cancer patients. This patient underwent a premaxillary reconstruction prior and was using an obturator. Because he had radiation, the obturator was no longer stable as the remaining dentition was starting to fail and become loose. On the bottom of the screen, you can see the patient without the obturator, and on the screen bottom right, you can see the dental prosthesis prolapsing into the oral cavity, creating a very horse-like appearance. This patient came to us purely for dental rehabilitation. This shows impressions of the patient and 3D scans with the obturator in place and the remaining dentition. The red shows the area of the planned resection, including bilateral infrastructure maxillectomy with the overlying dental arcade. For these reconstructions, we plan a 3-segment fibula flap, here with 6 dental implants. This slide shows the advantages of 3D printed plates compared to hand-bent plates. On the screen left is an omega flap, which was described by Matt Hanasono, Roman Skaraki, colleagues of mine from MD Anderson. To achieve a very similar reconstruction, they've done this with 5 pieces, and you can see the plate extending out laterally. With a 3D printed plate, a more elegant design can be achieved with the alveolar segments into the maxillary antrum, but with extension arms which extend to the anterior wall of the zygoma for fixation. Once again, you could never bend a plate like this by hand. This intraoperative view shows the precision and accuracy that can be achieved with 3D printed plates and medical modeling and the cutting guides. The reconstruction highly resembles the acrylic model of the maxilla. And on the screen right, we can see the flap once inset. 3D CT scan renderings of the patient's reconstruction show the rigid fixation, and on the screen right, the 6 dental implants. This patient is taken back to the operating room approximately 4 to 6 weeks after surgery, where we make a marginal incision, elevate the entire fibula skin island, and thin it, removing any subcutaneous fat. We then puncture holes through it corresponding to each of the dental implants. At the top of the screen, you can see the patient's preoperative anatomy when he was wearing the obturator. Now we've been able to close off the palate and achieved a fixed retained prosthesis with 6 dental implants. This is a postoperative photo of the patient with a fixed retained dental prosthesis. You can see his dental hardware is no longer prolapsing into his oral cavity. And on the screen right, you see some of the long-term side effects of the radiation process, and he has a shortened upper lip, which is very difficult to correct. He was much happier, however, and this allowed him an improved quality of life and a more stable outcome in the long run as the patient got older. In the last remaining minutes of this talk, I'd like to share with you some of our clinical outcomes that we've published in the medical literature. We performed a short-term outcome study looking at 90-day outcomes following immediate dental implant reconstruction in free fibula flaps on the mandible. We looked at complications, time to radiation, and proportion of patients achieving dental restoration. What we did is we compared a historical cohort of patients that had reconstruction with CAD-CAM on the mandible to a more recent cohort reconstructed the same way, but in the more recent patients, they all had immediate dental implants placed. And the whole series spanned approximately 9 years. First, we looked at complications at 90 days. The rates of minor and major complications did not vary between the immediate dental implant group and the historical cohort. Next, we looked at time to adjuvant radiation. In the immediate dental implant group, the mean time to initiation of radiation was 67 days. In the historical cohort, it was slightly shorter at 62 days, but this was not of statistical significance. We conclude from this slide and these findings that immediate dental implants do not significantly delay the initiation of radiation at our institution. Next, we evaluated the dental reconstruction process at the 90-day time period. On average, patients received about 2.5 dental implants. It took about 50 days before the vestibuloplasty was performed, and patients were wearing a temporary prosthesis that they wore during the entire radiation process by 55 days postoperatively. Out of the 27 patients that underwent immediate dental implant placement in this cohort, 14 or 52% of them had completed the dental restoration process by 90 days. In comparison, no patients from the historical cohort initiated any of the dental rehabilitation process at the same time point. When we look at long-term restoration in the immediate dental implant cohort and the historical cohort, we see that 74% of patients in the immediate dental implant group completed dental restoration, whereas only 12% of patients in the historical cohort completed dental rehabilitation. This was a highly significant p-value. The number of dental implants was not significantly different, but importantly, the time to dental restoration was only 90 days in the immediate dental implant group, whereas in the historical group, it took up to almost 3 years. In short, patients undergoing immediate dental implant placement were significantly more likely to complete dental restoration. The conclusions of our study are as follows. Immediate dental implant placement does not appear to increase short-term complications, nor does it lead to significant delays in radiation initiation. A higher proportion of immediate dental implant patients go on to complete dental restoration both at 90 days and in the longer-term follow-up period. One of the early criticisms of immediate dental implant placement was that perhaps it could interfere with radiation delivery. This study looked at immediate dental implants in free fibula flaps and looked at the short-term effects on radiotherapy in head and neck cancer patients. Overall, the outcomes demonstrate that immediate dental implants did not delay radiation nor increase acute radiotherapy treatment toxicity. And this also was able to be achieved with no changes to radiation dosimetry. When we combine our clinical experience as well as our outcome data together, we believe that immediate dental implant placement at the time of fibula transfer for either maxillary or mandibular reconstruction represents a new standard of care. The opportunity to place dental implants prior to initiation of radiation ensures a higher success of osseointegration. All patients at our center will undergo immediate dental implant placement at the time of bony reconstruction. Of course, there are going to be those patients that have complications and are never successfully going to undergo unroofing of the dental implants with the vestibuloplasty process. But placement of the dental implants at the time of fibula transfer is simple and straightforward and ensures the opportunity for complete dental restoration in the head and neck cancer population. Of course, there's additional work which needs to be completed. We need to follow up our patients over the long run and measure the improved health-related quality of life for the patient with the prosthodontic process. I want to thank the organizers of the meeting for inviting me to speak today and welcome any communications over email. Thank you very much.
Thank you for playing the recorded talk. Kishan, were there any questions? But I suppose we'll take them with the panel, right?
Yeah, no question at present, at least.
Okay. So I guess we then move on to the panel discussion. We've got 4 eminent faculty today who are going to be discussing cases with us. Got about 4 cases to go through, and a bunch of the usual topics. Even though the title of the session is oral rehabilitation after free fibular flap reconstruction, I think there are a number of issues that we would like to address that go beyond just oral rehabilitation in this particular population. Anyway, the panel consists of the who's who in head and neck surgery of the region. We have Jonathan Clark from Sydney, Australia, Dr. Fu Cheng-wei from Taiwan, Dr. Sun Hyun An from Korea, and Vijay Haribhakti from India. So I think without further ado, we can start the tumor board. Let me just share my screen. Let's see, where's my presentation now? Oh, there we go. Okay. All right. Presumably you can see my screen. All good? Okay. Great to see you guys. It's been too long since we've all met. Some of you guys, I think I met Vijay recently in Chicago, but I haven't seen Jonathan for a long time, I think. So good to see everyone. I guess we'll get
myself. Yeah. Yes, of course, Gopal. I remember very clearly. Yes. Yeah.
Yeah. And hope
so
you
nice
guys
to meet
well.
everybody. Yeah. Yeah.
Yeah. And this method sure beats traveling around the world to give talks, doesn't it? Good old Zoom. We can be at home having a glass of wine and chips and still sound rather academic. So anyway, moving right along, I'm just going to get to the first case. And what I'm going to do is I'm going to just go through the panel, have some questions back and forth. Feel free to interrupt if you have an opinion. Feel free to also look at the chat box. I think Dushan's going to be monitoring the chat box for any questions that's from the audience. It'll be useful if the audience asks questions as we discuss each case, because some of these things are more relevant to a specific case, and it's good to cover those things as we go along. Anyway, moving along. First case, 39-year-old lady, no major comorbids, young lady, young pretty lady who presents with the left mandibular swelling. A preoperative biopsy confirms this to be an amyloblastoma. This is a snapshot of the OPG, and I'll leave this on a little bit later. Just to go through a bit on the scan, the CT shows the lesion extending all the way up to the incisors on the left and all the way up to the sigmoid notch and a bit of the condyle moving up. Axial CT scans. And then this is the Panorex. So I'm going to leave the Panorex on so that you can use this to discuss as we move along. So I guess the first question is, maybe we'll start with Jonathan. Fairly straightforward. I guess the question is what sort of resection you would do, what that would entail, and how you would, anything special about planning the resection?
So she's going to require essentially a hemimandibulectomy. It looks like the tumor goes up to, what is it, the canine there, or the fore. So we'd probably be looking to come between the canine and the fore on the left-hand side. And we'd be looking at the extent to how close it gets to the condyle. I don't think can really appreciate that clearly on the OPG. My preference is to try and preserve the condyle wherever it's feasible, and using VSP approaches, you can design custom plates that will allow you to preserve very small segments of condylar neck and keep the condyle still vascularized if you use a pre-auricular approach to the resection rather than a sort of standard jaw split approach or cervical approach. But I can't really say whether that would be the case here. But essentially, you'd be looking at a hemimandibulectomy here.
what would be your minimum segment that you normally like to, before which you'd say you'd probably end up sacrificing the condyle?
So I need to be able to get 4 screws into the condyle. And we'd use the CMF screws rather than the standard 2mm mandible screws here, if we can. And those screws don't need to be in sequence. They can be parallel to each other rather than in a sequence of screws. So we can get away with as small as 1 centimetre of condylar neck. But it does depend a little bit on the patient's bone stock and their individual anatomy. It's not always feasible to do that.
Dr. Haribhakti, do you think it's any difference in how you would think about this?
I completely agree that I would most certainly want to preserve a variable portion of the condyle and the subcondylar bone, which seems possible, although I do agree this is not the best way to view it. I would certainly want to look at a high resolution CT in order to decide where the posterior limit of the cyst is and decide. My own feeling when I see this is that we can certainly save not only the condyle, but the subcondylar neck for at least about 2 centimeters or more, which makes all the difference, because then you've preserved even the lateral pterygoid insertion. And I think that does make a significant difference to the ultimate outcome. Anteriorly, yes, there is no question. We have to go all the way up to the lateral incisor, or even up to the midline. I'm not sure. I basically would say I don't go by an OPG to decide on the extent of excision. It's very important to see a CBCT or a CT with multiple sagittal reconstructions to know exactly at every point what is the status of the bone. Here the problem is we are not sure the spine is creating an artifact in the central portion. So I frankly would not want to answer it based on what I'm seeing now. But yes, that's fair.
That's fair.
That's what I would do. Yeah.
How often do you change your plan intraoperatively? That means when you decide to preserve the condyle, but then you end up having to take the condyle for whatever reason.
For ambuloblastoma, I would say never, because the information is all available radiologically. I honestly haven't encountered a surprise for the last many years. Yes, what you're saying would happen in the past, but not after we've got high resolution CT imaging.
And what would your planning margin be for an ambuloblastoma preoperatively? I mean, when you do the surgical planning.
Well, I mean, I would certainly clearly want to be about 0.5 centimeters away from the margin of the cyst, which I think is very achievable over here by saving a little bit of the subcondylar bone and neck. I see that, of course, as I told you, I'm seeing an artifactual arc over there. So if you could show us the HRCT, that would allow me to give a very qualified, but my impression based on this is it should be very possible. Yeah.
I don't know whether you can see better on this, but I think your point, I think I didn't put the cuts with the condyle there, unfortunately, to make the comment. Yeah. But anyway, I think the point is well taken. Dr. Fu, can I just ask how would you plan for the reconstruction for this case?
Actually, I missed the first part of presentation, so I may not be able to, get all those points. But for this case, in my practice, I have been doing this for more than, I think I started the fibula for mandible reconstruction in 1989, the same year that David Hidalgo, published his paper. But at that time, because the CAD/CAM are not emerged yet, so I have developed my technique. And in my institution, usually we have the resection part done by our oral surgeon, and we work closely with them. So the decision making regarding to the extent of excision basically made by oral surgeon. But I do agree with the two previous, comment, that idea that you're able to preserve the condyle to allow you to have at least 3 to 4 holes for fixation. And of course, recently we changed the reconstruction plate to mini plate. And so that, but still idea that you're able to remain some part to maintain. We adopt the so-called lure technique, before we make this excision, just fix that part to avoid the condyle dislodged from its location. So I think for the resection, I better pass to others. I can comment more on the reconstruction part. And basically we discuss with our oral surgeon and extend our excision. And then while they do the resection, then we start to harvest the fibula. And we insert after they finish their resection.
So since you
Gopal,
brought it
if
up,
I may add one point, since you had asked that question first, this was a case we did almost 18 years ago, and he's still doing well. When you're really not sure that you can save a lot of subcondylar bone, I have even done a complete hemimandibulectomy and taken the condyle and transposed it onto the fibular graft, and that has worked. We've not done it for a very long time, mind you. Today, we tend not to do it. But I'm only sharing that for ameloblastoma, I have done it on a couple of times many years ago, and it does work. So yes, I mean, I agree with Professor Y that the condyle is something really worth saving if it is safe and possible.
Well, since we're talking about reconstruction, can I ask Dr. Fu about the CAD/CAM system that you use, and how does it function for planning, and how do you normally plan these cases?
For this benign lesion, usually, in the recent, I like to say maybe only 6-7 years, we start to adopt CAD/CAM. But because of the healthcare system payment, we do not use the so-called complete CAD/CAM. We use the partial CAD/CAM. I will explain if I have time to explain to you. But basically, we try to have a lithograph and then allow us to have to contour the commercially available reconstruction plate. Of course, recently we changed to mini plate, and the need of that still there. So that helps us to, when we do the osteotomy for contouring the bone, or at the time of inset, that is helpful. But we don't have the, how to say that, the CAD/CAM made reconstruction plate. So this is maybe different from those that are done in other countries.
Yeah. Dr. An, can I bring you into the discussion? How do you normally do your planning for fibulas in this sort of situation?
I think our situation is very similar to the Taiwan because very recently the insurance system has approved the use of the 3D printing in the fibula free flap, but still the patient should pay a few $1,000s for except for the plus money. And as you know, the head and neck cancer patient is not rich in many cases. They are very poor in many cases, so they cannot afford the money. So we are still doing the traditional way. So with the reconstruct plate, before the resection, I bend it according to the original mandible and proceed to the fibula free flap. That is our situation, I think.
Jonathan, what about in Sydney? What are you doing these days?
So we've got two options that we would provide to patients. We would always use VSP in this situation. The two options are we can do our own in-house planning and 3D printing of guides and the anatomical models, or we can use the commercial providers to do the same plus a custom plate. If we do our own in-house 3D printing, then we'll use a commercial plate, whether it be mini plates or a reconstruction plate, and bend that to the model. So that means that some of the patients who are not insured or less financially able can still have the advantages of digital planning.
What are your timelines like for the two different systems? Are they different?
They're quick now. I mean, it used to be long, and that was one of the reasons why we started doing it in-house. You know, it used to take at least 6 weeks to get the guides and plates over from Belgium. But now we can get turnaround from industry in 2 weeks, and we can do the same in-house as well.
Yeah, I mean, we had a very similar sort of situation as well, where we were forced to start because of the delay, and similar situation with finances that all of you have described, that it's not really insurance claimable and therefore often out of pocket, and therefore the in-house system costs a fraction. But the main issue is that you don't get the 3D printed plates. Vijay, you wanted to say something?
I just wanted to say, I wanted to echo what everyone has said, and also add what we can get very, very inexpensively is a 3D printed mandible, even if the mandible is distorted by a mirror imaging of the normal side, and then we use it to bend the commercially available plate and use it, and honestly our results have been excellent. Yes, we would like to use cutting guides, but it just it works out very expensive. And also I think because we've not had the luxury of cutting guides for so long, somehow we get our cuts right. It's not so difficult. I'm only trying to say, I'm saying that it's not impossible to design your cuts accurately after a lot of practice. So whereas yes, we are planning, we do it in a very few cases, but most of the time it's a 3D printed mandible. We pre-bend the plate ourselves and we do the cuts by calc. We make templates and cut accordingly. That's it.
I think these CAD/CAM systems are very addictive. When a lot of places started, there is a healthy amount of skepticism, but after a while, most people realize that it turns an art into a science, and therefore allows consistency. And as Jonathan has always told me when I was much younger, we do it the same way every time. And so, you get that consistency with even the junior sort of surgeons. Dr. Fu, moving along, I was going to ask you that as well. What did you think about the virtual planning and consistency, and how it has maybe changed the way you do your reconstructions these days?
Are you asking me?
Yes, I am.
Okay, I'm sorry because I'm Fu Chen. Just call me Fu Chen, or call me Dr. Wei. Because when you say who, then I may not understand. It's me. As I mentioned, that we started this kind of surgery very early, much earlier before the emergence of the CAD/CAM system. So at that time, depend very much on the freehand, and just like just mentioned that. Because we have so many experience that we feel that although CAD/CAM is helpful, but it's not much different from regular practice without CAD/CAM. Because I have already gathered enough freehand experience. But I do agree that for the young generation, they start to learn this, it's better that they learn CAD/CAM. But before they, it just cannot. My suggestion is that they just cannot totally depend on CAD/CAM, because it may change. So far, the case we discussed that we didn't mention about the reach of the pedicle to the recipient vessel, and certain change intraoperatively and the soft tissue coverage need. So that is relatively straightforward case. The virginal neck and then the benign lesion. But come to the repeated surgery or previous irradiated, there are many things that can change the intraoperative planning. So you should maintain this flexibility. And if you do not must freehand and only able to do CAD/CAM, someday you'll be in trouble.
So tell me, how do you keep that training with your junior surgeons who come through? I know you have tons of fellows who come through. How do you keep them nimble and able to do both ways?
There are a couple of things. One is that they have to be familiar with the anatomy, and especially when we first operation, we always use the left side, and we managed to depend on the left side fibula. So they through this they're trained to be able to insert flap so that the vessel can reach the recipient vessel without being compressed. If they have this idea in their mind, then basically they're able to, do the, do it easier with CAD/CAM. And because we do have very, very good experience of fibula for mandible reconstruction. In my department at this time, we have around 2,000 cases of fibula for mandible reconstruction. And personally, I think I have about 800, for both benign and malignancy. So because of that, our experience, I do not want to say that CAD/CAM is not useful, but certainly compare with the other expenditure, that to spend that much money and to wait for 2 weeks, and you have to also explain to the patient that they need to pay this by themselves. It's very, very difficult task, because here everything is free, and you have to convince them if you want them to have the money from their pocket. So this is my comment. And if you train them in the beginning from freehand, then it's easier. They're able to handle with the CAD/CAM. But if you only train them with CAD/CAM, then they may not be able to. Every surgery, they may feel uncomfortable, especially those situations, as I mentioned, with difficult neck and the sudden change and of the surgical plan, or some modification or coverage issues. Those are my comment.
Dr. Gopal?
Yes.
Yeah, I will like to pose a question to the panelist. In our series, you have this is an example of ameloblastoma, and we have a pretty surety about the cuts of it, and we have done a CAD/CAM model. Once in a while, we come through in a squamous cell carcinoma of a similar scenario. But what happens is that once in a while, anterior or posterior marrow cut, which we have predefined, comes positive, and there is a tumor in that, and we need to revise that bony cut again. Now, if you have pre-fabricated CAD/CAM and you have already made your fibula cuts, and you have that fibula ready to put in your defect, this extra 1 or 2 centimeters of gap, how it should be managed, how it can be managed. Rather, I think Dr. Fu Chan can guide us better about it.
As I mentioned, that although we, because we want to be not fall behind in the technology, so in the recent 5-6 years, I start to adopt the CAD/CAM. But because of the extra expenditure, I only, ask the patient who had the benign lesion and want to have the so-called immediate osteogenesis, or even the so-called during the day or during the admission. Only those cases I want them to do this CAD/CAM preparation. And although they provide the cutting guide for the mandible and reposition guide and also cutting guide for the fibula cutting, but usually I like to wait for the benign case. I like to wait, even the benign case, I want to wait until they finish the rare resection, and they confirm that they won't change the excisional plan again. So at that time, this cutting guide may just, if the excisional plan doesn't change, then the cutting guide, you can use the cutting guide to facilitate your osteotomy. And I usually divide the vascular pedicle, from the donor side, and do the cutting bone osteotomy on the side table. I do not do it in situ because to me it makes no sense. The ischemia is not the issue, and if you do not do in a very well counteracted, with the counter action, the osteotomy may not be that, cannot be well done. So, and then in case intraoperative they have some change that increase 2 centimeters, then you can modify your cutting guide, or you can depend on your experience from freehand, and you're able to handle those situations. I myself, in the ameloblastoma category, the benign, personally, recently, I reviewed the cases that personally I have 140 something. And at this time, we haven't, actually just recently only one that recurrent because of the inadequate resection, but that was in the early stage. And I like to say in the recent 20, 25 years, I haven't encountered any single case that have recurrence. This means that since we're able to reconstruct the defect, the length is not the issue. So whenever you have any doubt, it's better to take the safety site. Not only 5 millimeters, sometimes can be even longer, just to avoid this kind of situation.
Thanks.
I agree totally with Professor Y. And Dushyant, very quickly, what I would say is the fibular osteotomies are never in our unit performed until the excision is complete. So I think what Professor Y said is very important. And I think it's very clear. The whole bone is lifted. We can even separate the pedicle, but the osteotomies are not made until the excision and everything is over. So we have flexibility. It's a long bone, so we can easily, it's never a problem.
Excellent points made by Dr. Fuchan and Dr. Haripatti.
Thank you. Thank you for both. I have a few questions about dental implants, but maybe I'll save it for the next few cases. So anyway, in this particular patient, we ended up doing a resection. This is a pre-surgical planning. Again, this is our in-house system, which is much, much more inexpensive. And in this particular patient, she ended up getting immediate implants as well. That's marked here. And this was the final product for this patient with the implants inside too that you can see, which was done simultaneously. So I just wanted to move on to the next case to illustrate some slightly different sort of variation. This is an older lady, again, no comorbids, but diabetic, hyperlipidemia. And this time we're dealing with a poorly differentiated squamous cell carcinoma extending from the first incisor to the first molar on the right side. Couple of images showing where the lesion is, and also a small level 1B node. And I guess this is a T4N1 mandibular SCC preoperatively. How does having a malignancy change the way you'd approach this with regards to planning, with regards to timing, and regards to margins? Maybe I'll ask Dr. An this question.
Yes, this is the, I think, very simple cases rather than the ameloblastoma. In fact, this is the squamous cell carcinoma, and I will do the segmental mandibulectomy, and margin will be about 1.5 centimeter in the bone, maybe, and mucosal margin, I wanted to make more than 1 centimeter, as the textbook says. And I will do the fibula free flap for the reconstruction. But I think that this patient, the tumor was not so big, right? Tumor was, yes, rather small. So in that case, I sometimes use the scapula tip rather than the fibula, because the scapula tip with the latissimus dorsi muscle can be good source of the reconstruction without any donor site morbidity. So if the segment is short, I will use the scapular tip, I think.
Okay. Actually, you almost answered my next question, but I'll come to that in a bit. Jonathan, how does this change your? Yeah, Vijay, you're going to say something.
Yeah, I'm sorry, I have to make this point because I've been bitten twice in my career, and so I'm extremely careful. It led me to do a whole study on the anatomy of the mandible. So if I find a 68-year-old or an elderly patient with obvious invasion of the mandibular canal, then I would plan my segments in such a way that the entire nerve-bearing segment is resected. And it may seem like an overkill posteriorly, but I would not take a risk, because if you later on find out that the nerve was infiltrated in the histopath, you just don't know what to do if you've taken a small margin. So I'm just wanting to say that in a poorly differentiated carcinoma in an elderly patient, perineural extension is known, and we have seen it commonly. And I would probably not risk taking a very narrow margin.
Thanks for that. Jonathan, how does this change your decision on what planning system you might use, or timings with regards to those planning systems for reconstruction?
Yeah, it doesn't really change our approach. We would still use digital planning for the patient as the preferred option. It just means we have to turn around the case as quickly as possible. And that means that the ablative surgeon has to communicate with the reconstructive surgeon from the start, so that planning process is not delayed. So we use a template that as a communication device, so that from the day the ablative surgeon sees the patient, they can fill out the template, they send it to the reconstructive surgeon, they'll make sure the right scans are ordered immediately rather than waiting till they see them, and we'll get the prosthodontist involved at a very early stage as well. So it's really just about making sure that your systems for digital planning are in place and flow efficiently.
And we talked a little bit earlier on about this change of plans that happens intraoperatively, and I didn't manage to get your views. So, I mean, how do you mitigate for any change of plans? Do you have a plan B up front, or how do you cope with that? Or what are your strategies?
Yeah, I mean, it's a really good question. It doesn't happen very often, but it does happen. And I think, first of all, you want good communication between the ablative team and the reconstructive team to let you know whether there is in the ablative surgeon's mind any doubt about where they're going to be cutting the bone as a starting point. And, there's many cancers where the margins are pretty clear and obvious, and there's other ones where it's not the case. And so in the ones where it's obvious, we would just do it the same way we would do for an ameloblastoma, and we would raise the fibula, we would cut the bone at the same time, and we'd have everything ready to inset at the time that the tumour's removed. So, a different approach to what Professor Wei has described, which, I absolutely agree is a very safe approach. But if there is doubt, if it's one of these cases where the tumour is ill-defined or there's uncertainty about where the resection's going to be, then we would still cut the bone, the fibular bone, but we would leave parts attached at the top and the bottom end, and that gives you the ability to change your plan if you have to. And to be honest with you, if the final solution is that you put in a bit of non-vascularized bone graft, I don't think it's the end of the world. Sometimes I've done that because I've made a mistake in my reconstruction, and you get away with it. It is important to put that non-vascularized section in an area where it is least likely to get exposed, however. So perhaps I'm revealing things that I shouldn't reveal, but that's the truth.
I mean, that's the reality of it, right? I always remember having a case where we ended up doing the same sort of thing and leaving a gap and thinking that this guy had extranodal extension so he wouldn't survive. And he sees me 12 years later with a horrible deformity, which he refuses to get addressed. So we see our mistakes all the time. Vijay, you're going to say something. I actually wanted to take you up on your comment about the nerve and whether a compartmental resection is one way to think about this rather than merely having a fixed margin.
Yeah. So all I'm saying is, if you see that CT which you showed us, the anterior margin can very readily be taken in front of the mental foramen, and so you have the anterior part of it out. Posteriorly, you don't need to go right up to the subcondylar bone. You can leave a segment. You can leave a 1.5 centimeter segment and angle your cut. So you take a straight cut down in front of just behind the coronoid process in such a way that the whole nerve is included. It's just that I have maybe been unfortunate to have not one, but two cases where we found that the nerve was involved and we got late recurrences at the skull base because the nerve was left behind. So I'm very, very careful about it. That's all. I mean, I know everybody wouldn't agree for a case like this, and you can, if you're 2 centimeters away, you're probably fine. I don't deny that, and you can get away with a small little segment of bone. But with fibula, a length is not an issue. So 2 centimeters more is really not an issue. So if you have the slightest doubt, it's better to be safe rather than sorry later. That's all.
I guess if you are the person to describe the cause of the inferior alveolar nerve, you cannot afford to be the one making the mistake on it, right?
Yeah, it was because of a mistake, because I saw a recurrence. I carried out that whole anatomical study. But yeah, I know, maybe I'm biased for safety. So that's all.
Dr. Wei, I wanted to ask you, what did you think about planning dental implants in these sort of patients with malignancies? Would you do it upfront? Would you plan it? Would you think about it?
Thank you very much. I think before I answer this question, I'd like to have some comment regarding to the reconstruction plan and excision plan. It seems we are able to back up the reconstruction, the resection team. So I certainly agree with Vijay that we should take into consideration the safety margin, because a little bit bigger, doesn't bother us if we prepare, our flap in a good manner. And here I like to comment on that, because I often see people that they design their skin paddle and design their bone. They want to remove smaller segment of the fibular bone, a smaller segment of the skin paddle. And this sometimes make no much sense. In my practice, I always like to have the bone, just make osteotomy about 6 centimeters above the ankle, and also below, the upper osteotomy. So that makes sure that we have the entire bone available. That gives you the flexibility of either to cope with the, change of more extension of the resection, or cope with the, inadequate length. Because if you have a long inadequate length of the pedicle, because if you do some vascular dissection on the proximal part, and then you split it, mortise the bone, then allow you to have a longer pedicle to reach the recipient vessel. And then for the skin flap design, if you design the skin flap, length is not the issue. I always like to have the whole length, as long as that of the bony osteotomy. But the width does matter. If you have the width less than 3.5 centimeters, usually you're able to do primary closure of the donor site. But once it's over 4 centimeters, it's become very difficult. So when you need to include 4 centimeter width or wider, it doesn't matter 4, 5, 6, 6. Anyway, you need to, after 4 centimeters, you need to have skin graft. Yeah. So you always have to keep this flexibility. This means that the excision, when they come to the intraoral lining or external face, either the compound or composite mandibular defect, they may change the excisional team. So if you have this kind of flexibility, especially preserve one side of the skin for the last minutes to cut, then you are able to have the amount of tissue. And also depend on the soft tissue that's included in the resection specimen. You can include either flexor hallucis longus, or you can include the psoas muscle. So, or you can make your skin flap wider and longer. That all help you to make up those soft tissue deficient parts. And this is my comment regarding to the way to. And then for this case, as I mentioned, that most of the oral cancer patients, they pay by the government, but the government won't pay dental implant. So if you convince them, I have several cases, they are affordable. So I was able to do that. But I like to say the majority of the patient, I don't want to do that. Because even I'm able to do it, I need to explain a longer time and to convince the patient, and they need to pay. And I don't think that kind of time I'm really like to spend. It's very strange feeling. Yeah. But if it's not if it's covered by the insurance, then certainly I will increase more cases. But our patient is different from maybe those in Australia, because many of them are bitter not chewer. So they have relatively limited mouth opening. The oral hygiene is really poor. So unless you're very confident and there's functional need, especially in the anterior part, otherwise I have been very conservative in persuading the patient to receive immediate osteointegration teeth in this, patients group that they need to receive the postoperative radiation.
Thanks for that. Vijay, you want to make a point?
Yeah, I completely echo. I think my philosophy is almost identical as Professor Wise. As a matter of fact, our the reconstructive team will do the entire dissection through the anterior incision only, and the final posterior cut is taken only after we have a complete idea about the soft tissue defect. So I completely agree, but that's how we do it. We do all the dissection. So it's practically ready. You just take the posterior cut after you know how much you need. And then we are never short of skin. And the other thing also, which you said, because implants are not paid for in our society also. So, there are just 2-3 things that are top of the mind thoughts, which I quickly want to share. If the patient is going to need radiotherapy, I'm less inclined to strongly promote implants. The best scenario is if there is a patient where there is a benign pathology and where skin is not required, that to my mind would be the patient I would prevail upon for implants. But if there is a patient who has a large T4 lesion and who's definitely going to need radiotherapy, I would be hesitant in promoting implants, because with every care that we have taken, the presence of skin, especially thick, hairy skin, and the presence of radiotherapy, I don't think we have solved those problems entirely. I'm being very honest. If any of you have, I'd like to learn from you, because when there is a full post-op radiotherapy and thick, hairy skin, it creates problems. So I just want to know from everybody. In fact, it's an unsolved problem for us, and I'm very honest about it here.
Can I echo on what Vijay just said?
Yes, please.
Yes, I think you know, in our career, when we begin, and we like to prove that we are able to do something. And so when you see someone able to do that, and you are afraid that you fall behind, so you want to learn from them. But after you have accumulated so many experience, you know what you can do and what you intention not to do. And then at the time that you make your decision, it's better. And I like to say I'm in this stage because I start the fibula for mandibular reconstruction, as I mentioned, 1989. And at this time, we have about 2,000 cases. So I haven't gone through all the stage. And especially if you look at the literature, the fibula with a reliable skin, that was first described by me in 1985, 86, 3 or 4 years before David Hidalgo, you know, used that. So when he applied the fibula for mandibular reconstruction, I was very excited because at that time I have already used the fibula osteocutaneous strap. I give it name osteoseptocutaneous because the septal vessels provide a constant, reliable circulation to the skin. So at that time, I have already done about 40 to 50 cases for compound long bone defect reconstruction. And I also performed the double bellow for the femora or for the humerus. So the osteotomy is the technique that I have already mastered just before he published this for mandibular reconstruction. So I was very excited and very thankful to David Hidalgo. And he, the first one that advocates using the fibula for mandibular transit. That make our life much easier. And before that, we use either scapula, as Dr. An said, or we use the iliac. And iliac is painful. And scapula, you have to wait until they finish the surgery. So it's a good, very, very good, move that we shift the donor side all to the lower extremity so that we can have two-team approach, so that we can have the surgery in a more comfortable manner. And this is what I like to comment. Thank you very much.
Thank you. Thank you. So interesting thing about this case, and that's why I said Dr. Ang preempted me actually. So we ended up doing a lower limb angiography with this patient, and there was hypoplastic posterior tibial artery bilaterally. And you started off by saying, Dr. An, that you would use a scapula in this case, even up front. So that's your preferred flap in such a situation with a smaller defect?
Yeah, in my case, yes, because if I cannot use the fibula. This patient's defect is anterior part of the mandible, so we need some kind of a bony flap. And in that case, I prefer to use the scapula rather than the iliac crest. The iliac crest is somewhat difficult to use because of the short pedicle and the design. So yeah, I like to use the scapula in this case.
Okay. Jonathan, what's your preferred alternative in this scenario?
So I would consider either a scapula. I would tend to use the lateral border over the angle, just because the bone stock is greater. Or I would consider using an iliac crest. That would come down to the soft tissue defect. I don't like the soft tissue component of the iliac crest because you can't rotate it easily around and manipulate where you want it to be, and it's often bulky. So if there was a sizable soft tissue defect, which there probably would be, I'd probably go for a scapula in this situation. I also prefer the scapula in older patients because it's easier for them to mobilize immediately after surgery.
Mm-hmm. Thanks. Vijay?
I mean, to be honest, we are so dependent on the fibula that I would really start scratching my head. But yes, I do agree with Jonathan that it would be the lateral border of the scapula. The scapular tips has a very thin, almost papery bone in our experience. We've used it for the palate and I didn't like that flap. So the lateral border has a much better bone stock. So So that's what we would go for, certainly.
And Dr. Wei, you mentioned a few alternatives as well.
Yes, I think before I answer the second question, alternative flap, I'd like to comment on the hypoplastic posterior tibial, bilateral. Actually, I have published paper I think in more than 25 years ago about the so-called, because at that time, people, even at this time, still worry about so-called peroneal magnets. And your case, hypoplastic posterior tibial artery bilateral, that is similar to that. But in my opinion, this may be a lead-in. If you're able to fill the anterior tibia and posterior tibia with either physical examination or Doppler, then even the angio showing this, I still proceed to use the fibula. And the way I harvest the fibula, I have the so-called, the approach. In the first dissection, I approach the lateral compartment. And after I dissect the peroneal longus and brevis away from the bone, then I enter the anterior compartment after I make my incision of anterior crural septum. And then I start to dissect the extensor tendon. At that time, you can examine the anterior tibial artery. And then after that, I may like to divide the interosseous membrane and enter the posterior compartment. And at this time, you can identify the posterior tibial artery and the peroneal artery at the same time. In case you have any doubt, you can let the tourniquet down and allow you to see the perfusion. And even through this kind of order, you don't make it irreversible, situation. So allow you. I like to say so far, I have only one case that I stopped because of the venous issues. And I do not do angiogram unless I cannot feel one of the anterior tibia and posterior tibia with my hand and with Doppler. So the angio is not routine. And in my opinion, I like to say, save the resources for another use. This is my first comment. And the second is that, as I have mentioned, the order of dissection of the fibula always allow you, in the reverse, even you make osteotomy, and after you make osteotomy, then you can see the peroneal artery and the posterior tibial artery. You can examine that. And even you find, theoretically, even you find that they are a poor condition, may compromise the circulation of the lower leg, you can refix the bone. And still, I haven't encountered anything case, but the theoretically it can be done in that manner. So this is my reason why in the past 30-something years, I have only 2 cases of iliac after I start to adapt. And the bilateral fibula is very safe. The patient still have no, a significant issue about the donor side. So it's because of that, I seldom use iliac. And I do have a few cases, but single-digit cases of scapula. And that is a good bone for the, short defect, especially when you need some soft tissue and longer pedicle. So this is my comment regarding to alternative drugs.
Thanks. Unfortunately, we also are very dependent on the fibula, and so there was not much expertise to do much else. So in the end, this patient underwent recon plate with ALT. But surprisingly, even post-RT, that didn't break through. It's not ideal, but she seemed to have fairly decent cosmetic result in the end. I won't go through the rest of the case because I want to get to what might be the last case, because we've had such a good discussion that I think I'm only going to get to 3 cases today. So I'm just switching gears from the mandible to the maxilla, because I think there were some questions even in the chat box I noticed about maxillary reconstruction, and I thought it's worth discussing this. 63-year-old male, again, no comorbids, no habits. has a right hard palate pigmented mass extending from alveolar margin up to midline. And the biopsy came back as mucosal melanoma, which most of you know is extremely rare. But this was really just localized to the hard palate with no metastasis seen on the PET scan. This is the CT showing very little sort of soft tissue component to this, but the PET tells you a much better visual of the extent. And I'm just going to show you the resection photograph as well, so you can appreciate how extensive this has been on the mucosa, requiring a fairly extensive infrastructure maxillectomy. I guess the question is, what would be your ideal or chosen way of reconstructing this? I guess I'll start with Jonathan.
So, I mean, mucosal melanoma is a tricky one because often it's quite diffuse and achieving clear margins is a bit of a challenge. So I'd want to put that consideration into the plan. If it was likely that the patient was going to receive post-operative radiotherapy, I've moved towards putting in a soft tissue flap first, radiating the patient, and then coming back and doing a bone flap reconstruction secondarily. This patient's going to, function much better with a bone flap. So the purpose of doing that is really just as a temporizing measure to get them through the radiation treatment. And the reason that I tend to do that is because with a mandible, you can't really leave the section like an anterior section unreconstructed. With the maxilla, you can get away with it. So you could even obturate this as an option for a period of time. This patient I would want to dentally rehabilitate if their prognosis was reasonable. So we'd want to put bone in to facilitate that. The other option for them is to use a zygomatic implant perforator flap, which is another thing that we've used for patients, but particularly older patients who are not with such good dental status, or those with limited prognosis. So there's a few options there, and we'd want to kind of run through those with the patient. But the first question is, is radiation going to be part of the plan for this patient?
Mm-hmm. And bone-wise, would you prefer the fibula, or would you consider the scapula as well?
Yeah, look, I mean, this kind of defect's really well suited to a scapular tip reconstruction. And you can implant the scapular tip if you've got the right type of implants. You need to use very broad ones. We use ones called the Max implants that are provided by Southern Implants. But you could reconstruct this very nicely with a 2-segment fibula with 4 implants as well. So I'd be talking to the patient about, what sort of activities they enjoy. This helps me choose between the donor sites, between a scapula and a fibula. If they're an elite soccer player, their career is over if they're going to do a fibula flap on them. If they're an elite tennis player, their career is over if you're going to do a scapula on them. So, these are things that I would be talking to the patient about to try and ascertain what's going to be the least morbid option for them.
What are your thoughts about early versus delayed dental implants with regards to radiotherapy? Do you think that it should be done after or before?
Yeah, so that's the question here. So if we put in a soft tissue flap, you radiate the patient, and then you put in a prefabricated fibula flap where you take the fibula bone up with the denture. So it's a very bespoke approach to this problem. If, however, you're going to put bone in first and then radiate them, I think it's quite important that you put the implants in before the radiation. And there's pretty good data suggesting that the rates of implant failure are lower if you put the implants in before the radiation.
Dr. An, can I get you to answer the same question as well? What do you think your preferred reconstruction and thoughts about rehabilitation?
Yeah, this is very difficult situation, especially in Korea. In Korea also, the integrated implant is not covered by insurance, and it costs very high cost. And also our dental surgeons does not want to do the osteointegrate implant even in the mandible. So in Korea, I think the osteointegrate implant in the maxilla is very difficult. And in my cases, in this patient, I will do just the anterolateral side flap for cover the palate, because the obturator will not working in this patient because the remaining tooth is too few and it will not fix it properly. So I will just cover this defect with the anterolateral side flap so that this patient is this patient age was 63, 64.
63.
Yeah,
63.
but still young, but by doing the anterolateral side flap, she can eat some food without problem or hygiene problem. So I will recommend it like this.
Dr. Wei, yeah, can I get your opinion on this?
Basically, Jonathan and Dr. An has already largely answered, how to reconstruct this. I think this is, in this case, the defect, the most important thing is that the reconstruction goal is to separate the oral cavity from the nasal airway, and then to allow uncomplicated wound healing so that the patient can receive subsequent oncology treatment. So that if that is the point, all the fancy procedures are not suitable in this case. So I agree with Dr. An that in this case, or either other case, when it's too complicated, involve the oral cavity, nasal cavity, and multiple structures, when you encounter that, just forget the algorithm that proposed by other pioneer about the maxillary reconstruction. In my opinion, it's better just to focus on the separation of nasal airway and oral cavity, and then get uncomplicated wound healing. And once the oncology treatment has been completed, and then you have already laid the foundation of the soft tissue coverage. At that time, if you do secondary bone reconstruction, rehabilitation, that will be easier. So this is my preferred treatment approach to this case.
Vijay? Yeah.
Yeah, no, I with complete respect to what all the previous speakers have said. When I look at this case oncologically, I feel the CT is not really revealing any gross bony erosion. I see that you have good 2 centimeter margins, which I presume have been validated by adequate frozen section assessment. I feel it is a very adequate, very sufficient resection that you have achieved for a deadly problem. And I would think, some of my philosophy for maxilla is very clear. Once the pre-maxilla is totally gone, it means we need to reconstruct it. I mean, I do completely respect every opinion that has been expressed, but my frank feeling is once the pre-maxilla is totally gone, it needs bony reconstruction. And I know it's at the risk of sounding boring, I would do this with a fibula, no doubt about it.
I think it's interesting because there are two things that has probably developed that changes one's practice in mucosal melanoma, or any melanomas for that. One is the advent of immunotherapy. And therefore, if you get good margins, as you said, Vijay, you're not going to see radiotherapy in most of these patients if you can get the good margins. I think that the issue is always this kind of field change effect you see in melanomas, which is always challenging to get a good clear margin on. But a lot of these patients go on to get PD-1 and CTLA-4 blockade and therefore can avoid radiation therapy. I think the second issue that we have more and more, you can tell just based on this man's dentition that he's a pretty high functioning individual. And therefore he expects a certain lifestyle, a certain appearance. He wants to go back to his, he's a CEO of a company, he wants to go back to that. And therefore, I think a soft tissue flap may be difficult for him to live with and deal with. And I think Jonathan hit the nail on the head with the dental rehabilitation as well. And in fact, that's effectively what we ended up doing. We ended up cutting guides, doing a resection, and this is the fibula, and we ended up doing a fibula flap with 3D reconstruction. And this is one of the few cases that we actually managed to get the commercial vendor to turn around fast enough for us to be able to do this resection and reconstruction quickly. Because usually, Jonathan, I don't know about you guys, but for us, it takes anything from upwards of 3 weeks to get this done in time. And that's the whole reason why we started our own in-house sort of program. I'm actually thinking that at this point, we've gone on for about an hour. I was going to get Dushyant to see what the participants, what burning questions our audience might have. Dushyant.
Yes, Gopal. I think we have a few very good questions. One is that what is the ideal height of fibula would you like to place for implant? And can you adjust your fibula up and down to achieve that purpose? And when you would like to double barrel the fibula? I will also like to add to this question, and I would like to direct it to Jonathan, that there is a recent discussion about even if marginal mandibulectomy is safe, you don't do the marginal because of the height and because of the implant problems, and convert it to the fibula, full segment and fibula reconstruction. I would like to know Jonathan's view about all of this.
So in terms of the height, what we would usually aim for is 18 millimeters from the occlusal plane in the incisor region and 16 millimeters from the occlusal plane in the molar region. So that's where we would set our fibula height. Now, if that, after placing it in that position, it looks like that there is a sizable residual defect on the lower border, we would then double barrel the fibula to fit into that space. And that varies from person to person, depending on their height of their mandible and their dentition, and the height of their fibula and which portion of the fibula you use. So it does vary as to whether we would put in a double barrel or not. I never double barrel the posterior section of the mandible, but I often will double barrel the anterior section for the contour. The question regarding whether you're better off just going straight to a segmental resection than a marginal resection, I think it's a challenging question. I never like to remove bone that's unnecessary, but from a dental rehabilitation perspective, it often makes it much simpler to resect the entire section of bone. And that's because when you do a marginal mandibulectomy, the residual bone is in the wrong location for dental implants. It's too lateral or anterior, too labial or buccal. And it has a long cantilever, which is unfavorable. I leave it up to the ablative surgeon, but when he says he's just going to do a segmental, I'm quite happy.
Dr. Vijay, will you like to have your views on this?
So see, you need to know the dimension. See, the typical implants are about 4.5 millimeters in external diameter and about 8.5 millimeters in length. So we firstly, I think the most important take home is you should do a CT of the fibula a priori to know what kind of fibula the individual has. Most of our patients, so fortunately, have fibulas that are at least more than a centimeter in width, and so that works basically. I mean, it's so because you need about 1 millimeter of bone on all sides in order for good osseointegration to happen. So I think I would take it all the way back and say that you need to know the kind of fibula that your patient has a priori, and that's very easily done with a simple CT of the fibula. Having said that, for the I will very honestly say we've not had a very good experience with double barreling. It was tried in 1 or 2 patients, but somehow it gave a very odd prognostic look. Maybe it was not properly done because we lack experience. So I am very humble about it, but the results were not great, and so we tend to as far as possible not do double barreling. And about the marginal, I totally agree. If the patient is keen on dental rehabilitation, no question, you have to do a segmental and put a fibula. You just cannot implant the residual mandible after marginal.
Dr. Fuchan?
Yes, I think I still, in this case, I believe that surgery must be successful, right? This case.
Right.
But I still think that for this case, unless it's only involved, may not enter the maxilla sinus or other structures. Otherwise, the fibula and cut in this manner, and you want to seal off, want to separate all the airway from the oral cavity, and then there's no open wound that won't cause infection, and then have a timely healing. Not mentioning that in this case, if you need the coverage and the pedicle, how to bring the pedicle to the recipient vessels. So all are challenged, not only this part. So in this situation, I still think that the safety is most important to get the uncomplicated, wound healing for timely, deliver of the subsequent oncology treatment. In my opinion, this is the priority, and we have to be, in reality. I have so many cases. In this case, I still to convince the patient it's better to do 2-stage. The soft tissue coverage, especially if you have adequate soft tissue, as Dr. An suggests, anterior to side, the contour are not much affected. Then when patients suffer from the severe illness, life-threatening issue, I think we have to remind them that we have to be, reality and the safety. So this is my comment. In this case, if it's come to me, I won't do that. Even I have so many experience of fibula, I won't do it. Otherwise, you may have the oral nasal fistula or nasal cutaneous fistula, that kind of issue. So I strongly recommend in this case, unless it's very low and very small, and you know that all the dead space can be completely obliterated with the bone and the surrounding soft tissue. And the pedicle ridge is not the issue. And the root of the pedicle is another issue. Which vessel are you hooked up to? The recipient vessel in this case. It's sometimes difficult to come to, the neck vessel. You may force to use the, superior temporal artery. And in that situation, artery is reliable, but the vein sometimes tortuous and very thin wall. The wall thickness discrepancy between the pedicle vessel and the recipient vessel. That is something I still remain my concern.
Thank you, Dr. Wei. We have another question also, and it is about which plate to use. Some uses 3D printed, some use recon plates, some use mini plates. So which are the good plates to use, or any guideline to use which plate in which scenario? And second is, are there any tips and tricks to avoid the extrusion of plates, especially post-operatively? Dr. Wei?
Actually, as I mentioned, that I start this kind of surgery very early, and in the early stage, I don't have many choice. I even use intosseous in the very first or second cases, and then afterwards I have a mini plate. Then I found that mini plate is inconvenient, especially when you need to have more than one osteotomy or two osteotomy. So when the a reconstruction plate commercially available, become available, I was very happy. So based on that, I can do some minor, further contouring based on the lithogram that we have. So, but after that, I found, the instance of the reconstruction, the plate exposure seems higher in the cases of using reconstruction plate. And also the management is more complicated, especially when the wound is still not healed yet. And the wound at the bone had not healed yet, and you have the exposure. That is a problem. So in the recent 2 years, I came back, and because of the accumulation of more experience, I'm able to do, use the mini plate to fix in between the osteotomized fibula, or between the fibula and the denating mandible. And then that made, in my hand, become easier. So I use that. And it seems to me from these 2 years, the past 2 years, seems to me that the reconstruction plate exposure issue is less than that of the, reconstruction plate. And even their exposure of the mini plate is more easy to manage than the reconstruction plate. Even it's still not here yet. You can refresh the end and you can do, another fixation. And so this is my current practice. So I like to suggest that if the coverage is not the issue, intraoral lining is not the issue, and it's a long segment of the mandibular defect, reconstruction plate is I suggest, especially when you have the custom made, that even better. But if you don't have the custom made, then you can use commercially available, and we're doing some minor modification. But when they are only one segment, at this time, I prefer to use the mini plate just to fix it. And when you have more experience, maybe in 2 segments, you still like to use a mini plate. And the advantage, as I have already mentioned. Thank you very much.
Thank you, Jonathan. Your views on this?
For maxilla, I would always use mini plates. The space you're working in is very tight, and it's hard to get a reconstruction plate in there. The mandible, we tend to use reconstruction 3D printed plates as the preference. That's just because, as Dr. Wei has indicated, they're easy, and I like things being easy. And in terms of preventing exposure of the plates, I think that's really important, that you've got good soft tissue coverage. It's one of the reasons we always use an ipsilateral fibula, so that you can drape the septum of the skin paddle over the plate, provides extra bulk, and reduces the chances of plate erosion through the skin.
Jonathan, I'd like to comment on your comment regarding to the laterality. It's very, very difficult, very, very difficult. If you take the laterality into your consideration for reconstruction, to me, it's very difficult, because you have to think about, the extent of the resection and how close is that to the opposite side. And you also have to take into consideration those patients, they may have previous surgery on the neck, on any part of the neck. So if you are bothered by the laterality, then you always have this kind of issue. There's no algorithm allow you to make very nice, to guide the young generation. So in my opinion, just forget the laterality. And I would suggest that always try to use the left side fibula as your first choice, unless you find it's not suitable. And then we have to learn from this freehand and other experience accumulation. We have to learn how to allow the vascular pedicle to reach the recipient side, either in the ipsilateral or the contralateral, and without being compressed. And it's not always necessary to press the so-called mesenteric side inside the lingual side. It's not always like that. You can even turn it out. And if you are able to see the peroneal artery is close and make a minimum dissection to the periosteum, you still allow it to press on either inside or outside of the lingual side, or the lingual side, or the external side. So this is my suggestion, because I don't think that many people have the enough numbers that they can divide it ipsilateral, contralateral, and when the neck, this side is available or not available, and when it's come to the facial artery, come to the superior side, come to the transverse circle artery, it's very difficult. No one has that. So it's very difficult to guide them with it. So just, my philosophy and my experience saying that always try left side, unless it's not reliable, and always able to handle. You can put, this is the like the mesenteric side, carry the vessel. You can press this in the lingual side, or you can press it outside, provided when you drill a hole or do the inter-implantation, just avoid direct injury to that. It's all visible. So my suggestion. Thank you very much.
Thank you, Dr. Wei. I think we've probably come to the end of our session. It's, I think, close to 3:30, and we've had a really good discussion with all our speakers. And I want to thank them for actively participating in rendering their opinion, agreeing and disagreeing, and sharing their wealth of experience with us. Thank you very much. I am handing back to Pankaj, who's the man of the hour now.
So thank you, Gopal and Dushyant. On behalf of Ifhnos, I would like to thank all of you. And as usual, unlike any other branch of medicine where evidence-based medicine is the mantra, surgery is one specialty where experience comes more handy than evidence many a times. So experience-based medicine, it came out very, very strongly in this panel discussion, and I really appreciate all of your contribution. And it is certainly heartening how the discussion went on and how Gopal and Dushyant made certain very, very good cases, and how there were differences, but we all have one goal, that the patient should go home happy. And that is what we achieve in India, in Taiwan, in Australia, in Korea, in Singapore. We all work in different ways with the same goal. And that's what came out very strongly. So thank you, everyone. And thank you, delegates, for your participation. See you soon, sometimes again.
Thanks.
Thank you.
Thanks, Pankaj.
Thank you.
Thank you, guys.
Bye-bye.
Bye.
Bye, everybody. Thank you. Great being on this panel. Thank you, Pankaj. Yeah.
Thanks.
Thank you very much. Thank you.
Thank you. Thank you very much, everybody.